Hello. Good morning. I'd like to welcome everyone in the room to this meeting of the Health Overview Select Committee Hall. It is also being streamed live on the County Council's YouTube channel. A fire alarm test is not expected during the meeting. If the alarm sounds, we must evacuate County Hall. In the event of an emergency, please make your way to the nearest exit and meet at the muster point located in the main car park. I'd like to welcome a new committee member, Victoria Holliday from North Norfolk. Welcome. I hope you enjoy the committee. I'd now like to ask Holly to provide us with details of any apologies and substitutions.
Good morning. Today we have apologies from the Vice Chair of the committee, Councillor Devula Pali, and she is substituted by Councillor Alexandra Kemp. We have apologies from Councillor Savage, who's being substituted by Councillor Fisher. We have apologies from Councillor Wilkinson and from Councillor Cork, who's being substituted by Councillor Deborah Sachs.
The next item, as Pallavi isn't here today, we need the election of a vice chair for the meeting. The vice chair has to be elected from one of the Norfolk district councillors and the committee. The person doesn't have to come and sit up here. I just need somebody. If they want to, they can. So could I have any nominees, please, for that? Jeanette, lovely, thank you. And you'll second, Paul. Is that okay? Thank you. Can I have a show of hands to see if people agree with that? Thank you. Jeanette, are you going to stay there? Okay, thanks very much. Okay, item 2 on page 5. Can I ask members to confirm that they're content with the minutes of the meeting dated the 6th of November and that I can sign these as a true and accurate record of the meeting? People happy with that? Thank you. Do any members have any interest to declare regarding any item covered on today's agenda, please? Jeanette.
Yes, I need to declare that I'm a patient.
It's already been called in to the Secretary of State for Health. It's already been called in to the Secretary of State for Health and Social Care. I'm going to raise this under item 9, the Forward Work Programme, and will propose an approach this committee can look to take. Is that okay with everybody? Thanks very much. Okay, moving on to Section 5 of our agenda, Eastern Pathology EPA, weekend pathology testing. Can I welcome representatives from the Norfolk and Waveney Integrated Care Board and the Norfolk and Norwich Hospital, in particular Dr. Shane Gordon, who is new to this. Welcome, and I hope you find this rewarding. Can I ask that when representatives first speak that they introduce themselves and provide us with their job titles, please. I'll now hand over for a brief introduction to the report.
Thank you, Chair. My name is Dr. Frankie Swords. I'm the Executive Medical Director of NHS Norfolk and Waveney ICB. So to start with a little background and then very, very much taking you up to the minute where we are with this decision. So concerns were first raised by the Trust a year or so ago that the overall spend on pathology, so that's blood testings by and large, and on the processing of routine samples that we received at weekends was increasing. Weekend testing was introduced in 2020 on people, particularly those either of working age or those reliant on people of working age to bring them for their tests, for whom it's much more convenient, as per the paper, into this. And we're looking at this review, and I'm very confident of this, to have agreed a way forward by the end of February, so imminently, and we are very happy and keen to give an update to HOSC then, so I can't quite give you the answer yet, but I'm anticipating that will wrap in weekend provision, and I'm very happy to bring an update in March once that decision has been taken and once we've finished those contract negotiations.
Thank you for the introduction. Please ask that when you first speak, you introduce yourselves. And I'd also remind you that this must be for the purpose of providing the committee with additional information or a different perspective. You can't ask questions of the representatives. You have 5 minutes to provide additional information to the committee. Once the allotted time has finished, no further contribution from the speakers will be allowed. Thank you. Could you introduce yourselves?
Yeah, good morning. Good morning, Chair. I'm Jonathan Knights, the Executive Manager at East Norfolk Medical Practice. And I'm accompanied by my colleague Rachel Haycon, who's our Finance Manager, and will speak shortly after me. Thank you very much for giving me the opportunity to address the committee. And I'm pleased to hear that there is some review of the service going on. Excuse me. The concern really for us is the decision-making by the ICB and the consideration of the impact of decisions on the most deprived populations that we serve, the core 20 plus communities. We are a large practice serving 32,000 patients in and around Great Yarmouth. The vast majority of our patients are resident in a core 20 plus community. Excuse me. The ICB have made some clear public commitments to those communities and to reducing the health inequalities gap. And the decision for this particular service, and not just this service, but also other previous decisions, for example, the decision to reduce or pull the homeless funding for our population, are, to me, in direct contravention of the publicly stated commitments to those communities. So, for me, I think that it's about understanding those decision-making processes and making sure that they are in line with the publicly stated policies and commitments, so that we are not making the problem for the patients in these communities that already struggle to access healthcare services, excuse me, and often are unwilling to access healthcare services, and we work very hard to try and make sure that we can do that the best we can. We're making it harder. The decision to take away that weekend service it has no doubt had an impact on the ease of access to the patients in our community. So, just to add to that, I think that it's the decision that we received was with no notice. The service was stopped within a month of us being told that it would. There was no explanation of how the decision was made, and that is totally in contradiction to what should be happening, which the ICB have stated themselves. Decisions should include robust evaluation for potential impact on core 20 plus communities. So I think that's what I need to say, and I'll hand over to my colleague Rachel. Thank you.
Yeah, hi, I'm Rachel Haycon, Finance Manager at the practice. Just to pick up a bit more about the history of this service for us, we've actually run it since 2018, and it was jointly developed with the Commissioner at the time. The CCG were really supportive of it, and we all recognised the positive impact that weekend phlebotomy could have on patients. And it's run since then. It's always been incredibly popular. We rarely have to try and fill Saturday appointments. They are really well liked and well used. Just to give a kind of a few patient examples of what it's enabled us to do, it's let us run things like diabetic care, diabetic gait care process appointments at the weekend where patients can have their bloods done and everything done all at once. And for those who work, that can be really tricky to achieve in the week. It's enabled patients that work shifts away from the Great Yarmouth area. We have quite a few patients that are in that situation, and it's enabled them to come in on a weekend and access care. Patients, as you've already said, around who need accompanying at the weekend, patients that just struggle to get time off work because of their working lives and how, you know, the sort of jobs that perhaps they're in, that can access that care. So kind of, I guess in summary, it's always been a really popular service with us, and the decision was taken obviously to stop that without kind of any reference to those patient groups and discussion with us as a provider who've done it for 7 years as to the impact of that. And do really welcome kind of what the ICB have said this morning, that that's kind of being reviewed.
Thank you. Thank you for your contributions. I'm now going to offer an opportunity for the representative from the Norfolk and Waveney Integrated Care Board and the Norfolk and Norwich University Hospital to provide a brief response.
Thank you, Chairman. So I'm Shane Gordon. I am the new Executive Managing Director at the Norfolk and Norwich, and I've been in post for 6 weeks now, so still familiarising myself with all of the nuances of the relationships in the area. I'm a GP by background, so I have a lot of sympathy with the points that my colleagues have just raised. And I'm also delighted with the very positive conversations that we have entered into with the ICB around the provision of weekend pathology services. I think the paper sets out some of the challenges that we face. I've had some extensive discussions with colleagues in the laboratories about the logistics of providing the testing at the weekend. And I'm in no doubt that it is a considerable challenge to the lab to be able to provide the testing under the current staffing arrangements. So it's not a trivial problem to overcome to do this. However, for all of the reasons that our colleagues have indicated, we want to work as constructively as we can with our commissioners and with our partners in the community in primary care to ensure that patients have the best access to diagnostic testing that we can possibly provide. And I do recognise that there are particularly working age people who find it very difficult to access GP services during the weekdays. So the fact that we are already in negotiations and discussions about finding a constructive way forward to this, I think is very positive, and I am hopeful that that will reach a conclusion which allows us to meet the needs of our population as best we can.
Thank you very much. Can I have questions from the members, please? Okay, who do I have? Gosh, lots of people. Okay, Stuart, please to start. Thanks.
Yes, thank you, Chair, and good morning, everybody. And I'll preface this by understanding that there are considerable cost pressures for the ICB and also the wonderful work that's done right throughout the healthcare system. But I do have some concern around this, and particularly if I can refer to page 23 of our packs, which is paragraph 4, which is the degradation rates, particularly around blood after 24 hours. And within the packs, we'll see that 70% of the testing is being now sent up from GP surgeries. So the issue for me is that we need to remember that these are quite invasive things, particularly bloods. They are a nervous time for people who are waiting for the results back. And there is a demographic issue that we've been raised, but there's also a geographic one. So I represent people in the west of the county who are going into GP surgeries to be tested, and then they have to get the bloods from there to the labs. Now, we have had reports here in the past where, because of degradation, what's happened is that people in the West have had to have an unduly high return rate of, we need to do this invasive procedure to you again because of that. So I've got a concern around that in West Norfolk. And the issue for me is around this, is that we're talking around weekends, but the question for me would be, if blood is degrading within 24 hours, surely that means our GP surgeries can't actually take blood tests on Thursday, from Thursday onwards now, for the further pieces of the county, because of the fact to get them over, if they were taking them on the Friday, to get them over from Friday afternoon onwards, they'd be hitting the lab and no one would be doing it till Monday. So what's the point of taking bloods on a Friday? Unless I've got that wrong. So actually it's not a 5-day service you're offering, it's a 4-day service, because practically no one's testing it for the whole of the weekend. I'd like an answer on that. Have I got that wrong, or are we actually offering a 4-day service rather than a 5-day service? Thank you.
Will be tested on the Friday, and our testing on every day goes 24/7. The difference is that at 8 o'clock on a Saturday morning, the staffing in the labs goes from 12 biomedical scientists to 2. So we'll cope with the weekday demand absolutely.
If they do those on a Friday morning or a Friday afternoon, you actually will be doing those tests. If they do those on a Friday morning or a Friday afternoon, you actually will be doing those tests Friday evening, will you?
Yes, which is what we do. What we do now. Yeah.
Thank you.
Thank you. Leslie, please.
Thank you. I represent Kings Lynn North and Central, and I noticed that on the chart, can I just ask about the chart though? I know it may be incidental now, but the preamble says that the numbers at the surgeries does not reflect the number of patients. But does it reflect the number of, I mean, I was surprised that the surgery has 20,000 patients. You just mentioned it earlier. And so my surgery, for instance, I wouldn't have thought it had 20,000, but I don't know. I've never asked the question. And it moved from the town centre 2 miles away, which means that it's all right for me to get some there at any time if I'm driving, but when I'm not able to drive anymore. So my division is Central, which is the centre of Kings Lynn, and North. And North has a surgery, the Healthy Living Centre at St Augustine's, but I can't see it on this list. And it is a difficult area. It's an area that is made up mostly of social housing, and there aren't that many buses. There are buses, but so for somebody to have to go to the Queen Elizabeth Hospital, that would be as complicated as going to St James's medical practice. But so I wonder if it is, if it does carry on, if that could be considered, because the North Lynn part of my division has the highest or the lowest life expectancy, and this was highlighted when the Marmot Place was set up. I think it was year before last now, and it suffers greatly, and I am very concerned about the people of North Lynn and how they access health easily. So for many of those people, they could possibly walk to St Augustine's for a test, but they could continues. But do the numbers reflect the number of patients? I mean, it says it doesn't reflect the number of patients, but does it reflect the number of patients that are actually in those surgeries?
Thank you, Councillor. Actually, it is very variable. So some practices, like East Norfolk, have a service on a Saturday morning and their staff were set up to do those diabetes annual reviews, for example, but it varies enormously. And so the table, which is a bit difficult to understand, indicates how many tests are sent by each surgery. So one patient might have 4 tests, another might have 1. So that's the first thing that makes it a bit confusing. But secondly, depending on the staffing model and the local needs, you might have a very large surgery that hardly does any tests at weekends, and you might have a small surgery for whom it's really vital and they do lots of tests at weekends.
Thank you. Alexandra.
Thank you. And I represent Kings Lynn South, and that's also in the Core 20, and a lot of deprivation. And the way that this decision was taken, where, for example, the East Norfolk medical practice, because they weren't consulted at all, it seems to me that it's not really driven by patient need. I mean, in the context of everything with the hospitals, we have huge problems with waiting lists and diagnostics as part of that. So surely everything should be done to increase the testing, and we should be working towards 7-day testing to clear the backlogs everywhere. But also, we're not making use of the resources that we already have, because we have a new £12 million health centre in South Lynn, which was built when St James's surgery moved to Wootton recently. But it was earmarked for a community diagnostic centre, and it would have been so much easier for people in the town in South Lynn and people west of the river to get there, because there's no direct bus to the hospital, for example, for tests. But there are no plans at the moment for a diagnostic centre. Now, don't you think it would be really beneficial to review that and to put an additional diagnostic centre for the community in the new Southland Health Hub? Because that could greatly improve the health of the people in Kings Lynn by cutting the waiting times and making sure that people access the support they need earlier.
Thank you. I absolutely take your point on how the decision was taken, and I think it is fair to say that this was a financially driven decision. We did undertake quality impact assessments and equality impacts, which didn't raise too much concern, but actually having taken it, we're seeing that there is more impact than was anticipated. But you're right, we didn't take this decision from a point of view of how can we maximise access, how can we be as good as possible. It was driven by a financial issue, and that is why we are reviewing it. In terms of our community diagnostic centres, so a couple of years ago we had none. We now have 4, I think, in Norfolk and Waveney. So there is one at Kings Lynn, there is one on the University of East Anglia site just next to the Norfolk and Norwich, and there are 2 in Yarmouth and Waveney. I'd like to have dozens. I'd like to see one in every neighbourhood, but we have been rather constrained by the finances. So we've got 4 so far. It would be great to have more, though. I absolutely agree with you. And as I said earlier, I think we need to be moving to make things more accessible, not less.
Just might follow up there. Have you factored in the cost to the country of so many people off sick? We have a high proportion of people that are signed off sick in this country. And surely if you were to factor that in, it would be much more productive and financially beneficial to increase the number of community health diagnostic centres and to have 7-day-a-week testing, wouldn't it?
Yes, as I say, we would like to move to more 7-day testing, and the whole, I think the drive of the NHS long-term plan and the 3 shifts is really about taking into account the wider impact of ill health. We need to do more on prevention. We need to do more to maximise our use of digital, but also other innovations. And we need to do more to bring care closer to people, not squirreled away in big white hospitals. So I agree with you. I don't have all the answers, but I do agree with you. If I might make a slightly cheeky suggestion, though, I do think we also need to look at our public transport provision, because you've highlighted a couple of excellent resources which are not well linked by public transport, and I think that is a challenge for us in such a dispersed and rural county.
Thank you. Can I just check? I've got people wanting to ask questions. I've got Jeanette, Lucy Shires, I've got Victoria and Lucy G. And Paul. Okay. Anybody else? Okay. Thanks, Richard. Lovely. Jeanette, please.
Hello. Thanks, Chair. I was really surprised to see that the impacts of the withdrawal of the service were limited to what you called convenience and choice, because the reality in Great Yarmouth is that you have working people working in very low-paid jobs. And actually, sadly, that usually means less flexibility to get to appointments, no time off work when you're undertaking that kind of contract. Also, I just don't understand how the medical professionals can be effective at the weekend if they're not allowed to take samples, to do diagnostics. It just doesn't work. It really doesn't. And it means that people have to have, extra visits. My question really around this was, why was there no consultation with the practice or patients? We have a very good patient participation group, and if that question had come before us, we'd worked hard with the practice to enable things like Saturday appointments. So how can we ensure that this kind of thing doesn't happen in the future? When services are going to be impacted, surely the people offering the services need to be consulted, and the patients do too. what else was I going to say? I think you might have already answered this question, actually. My next question was, I felt that, you know, the decision rendered the medical professionals, you know, less effective. So my question was, can this service be reinstated? I really feel that it does need to be reinstated urgently. Thank you.
Thank you. So I think there's sort of two parts to that question. The first is straightforward. So in terms of you said how can clinicians do their job if they haven't got access to diagnostics, essentially. So at no stage were diagnostics removed for urgent care or for people attending our out of hours or urgent provisions. And generally speaking, when diagnostics are performed in primary care, it does take a couple of days to get the result back. So actually, in terms of when you're seeing a patient, if you do a point of care test, that is, say, a finger prick on a machine, get an answer straight away, that would be completely different. But otherwise, if somebody needs a blood test, you wouldn't get the result until Monday anyway, and the evidence shows that people weren't often looking at the results of blood tests that were taken on Saturday because they were routine, they were annual reviews, they weren't actually being looked at until Tuesday or Wednesday anyway. In answer to your, so hopefully that answers that aspect. In answer to your other question about why we thought this wouldn't make such an impact, well, the equality and quality impact assessments were undertaken in good faith, and in advance we thought that was going to be the main impact, but we were wrong. And so we have found that it has had a greater impact, and so that is why we are urgently reviewing this and optimistic that we will be able to have a new position to update you by the end of February with a view to things being set up for April for the new financial year. And the final point, why aren't we talking to patients more? Yeah, why aren't we talking to patients more? I think I need to take that back to the ICB to look again. I could give you lots of excuses, but there'd be excuses.
Thank you. Appreciate that. Thank you.
Thank you. Lucy Shires, please.
Thank you, Chair, and Happy New Year to everybody. It feels a bit odd saying that. I just want to raise for the committee, it's not very often that we have any healthcare professionals here saying they're looking at potentially reversing a decision. And they've already done that work before coming to committee. Normally, we're bringing people into the room, asking them some really challenging questions, and then we're hoping to get change. We've already got change in front of us, hopefully, and I think that's really positive, and I just wanted to raise that. There's been a challenge already about language, about convenience, and I think it's a little bit unfair to say that working age people are choosing a more convenient service. They're often choosing between whether or not they can feed their families and take off time from unpaid work. So let's talk about how healthcare is largely inconvenient for working age people. And I think this is a small part of healthcare, but I would really very much like the committee to think about how we challenge accessible healthcare for working age people. Many of us in this room have juggled health and families and everything else, and we've had to work around healthcare, but I know there's been a shift in the way that health is provided. So I would like to make a recommendation that we do look at the wider impact on working age people and how we can support our healthcare professionals and providers into making the changes that Norfolk does need.
Thanks. Do either of you want to? No? Thank you very much. The next person is Victoria, please.
Thank you, Chair. Thank you very much indeed for the report and for coming today. Unfortunately, we don't have weekend testing at the practice in North Norfolk. We seem to be neglected, so it's something we should consider. So you might need to factor the expansion into rather than just the reinstatement. I'm a little bit disappointed that the clinical impacts of this decision have been somewhat overlooked, and that the human cost and the system and clinical cost of poor routine care or because the patient can't actually get, as many people, my colleagues have said, can't get to the surgery during weekday hours, hasn't been taken into account. And it seems to me, I mean, if you don't have your diabetes or your cardiovascular disease monitored regularly, you're going to have some pretty hideous outcomes, and that doesn't seem to have been factored in anywhere here. And I don't know if you ever do this because I'm a new bug, but wouldn't this have been quite good to pre-scrutinise before that you actually took the step, and then some of these things could have been flushed out? Because, I mean, all the interesting data has come in retard of the decision being made, and the information that the decision makers had was very limited, actually. And I'm disappointed at that. Thank you.
Thank you for the comment, yes.
Thank you, Dr. Holliday. I suppose the point you make about the clinical impact really goes back to the variability of usage. So many practices still choose not to offer weekend testing at all. So there is a huge variability, and at no stage was the intention to reduce the number of people who were able to have their long-term condition checks. Absolutely not. But as I mentioned earlier, it grew rather organically. So although I wasn't aware that there had been a service in the East prior to 2022, in terms of the ICB, so Norfolk and Waveney, rather than the 5 previous CCGs, this only sort of came in rather informally in 2022, and it's very, very patchy. Many surgeries barely use it at all, but their patients obviously still have their long-term condition checks. So I think the clinical impact wasn't anticipated to be significant. But as I say, our anticipated impact and the real impacts were slightly different. So we've got more information now, which is why we are reviewing this.
Can I just ask a question? Seeing that the equality impact assessments didn't pick these things up, how are you going to improve? How are you going to improve your assessments?
I'd like to take that away, if I may, Chair, and give you a proper answer once I've taken stock and spoken to the team who run the equality impact assessments, because like the earlier point about involving patients and service users more in our decision making, I think we need to give that some serious thought.
Thank you. When you've given it some thought, if you could let me know, then I could distribute it to the members of the committee if the committee's happy with that. Yeah. Okay, Lucy Galvin, please.
Thank you. And thank you for the report, and thank you for coming in and asking questions as well, and making those statements on it. It was very useful to hear from people directly impacted on this, so thank you for that. I think one interesting thing to say that this committee is supposed to be looking at transport and health. You raised that, Dr. Sword. So we've asked to do that. I don't know where it is on the work programme, but that was definitely raised by the Vice Chair multiple times, the impact of transport on healthcare. So I really do hope we can get to that, because we see it time and again how important it is. But that's a side point. I wanted to sort of echo what Councillor Jones has said, what our Chair has said, that we've heard that the decision-making questioned around, especially around vulnerable users and the impact on them. And we've had an honest admission that the EQAs didn't work in that sense, which is really concerning indeed, because if they didn't work for this, how do we know they've worked for other services? So, you know, other commissioning that's happened, or decommissioning in this case. How can we have any faith in any of the EQAs? And I'd like to go a bit further and say, could we have a look at the EQA process here through this committee? I mean, this may be a first stage of reporting back, but I think it's a really serious point that services need to be properly looked at to provide care to the most vulnerable, who often don't have a voice for themselves. And if the EQAs aren't picking that up, we need to see that. And thank you for the willingness to talk about that. And I'd say we could look at it with Health Watch. I could see Alex. And could we look at it as a committee? And would you be up for doing that, and perhaps pre-scrutinising it as has been suggested, and working sort of with the committee on it? I'd like to ask if you'd be willing to do that. That's the question, really. Thank you.
I think that's a really good idea. And as I said to the chair, I need to go back and do some homework and find out. So I think I don't see any reason why we couldn't bring the EQIA process and an update on how it works and how we're trying to always improve it, because you know, it isn't infallible, clearly.
Alex, I think you'd like to say something at this point.
Thank you. Mine's just a plea and an adjunct to what Lucy's just said, is that can I make a plea that Health Watch is involved, please?
Okay, thank you. Paul Neal, please.
Thank you, Chair. A lot of my questions have already been talked about. And it's very refreshing that somebody is admitting that we might have got it wrong and willing to go back and review it. So that's very positive. It was mentioned about there's the logistic issues with testing by doing it on a Saturday. And currently there's 2 staff doing it. What were the numbers when you were doing Saturdays? And is the logistics issue about staff willing to actually having to work on a Saturday?
Thank you. So the numbers were the same when the GP testing was being done. So there are 2 factors that we need to consider in that. One is that the volume of testing coming from primary care was growing quite steeply year on year. So what had started off as a relatively small number, circa 400 tests a day, had grown to 1,000 tests a day by the time it ceased. So that's a 2.5-fold increase. And the volume of testing from the hospitals and other urgent testing in the community had also increased over the same period. So the 2 lab biomedical scientists who undertake the testing are doing a workload which is about 35% higher than their compatriots during weekdays now. So there is a sort of step in resource required if we were going to continue to do that as a routine weekend service safely. And that's the subject of our discussions at the moment about what the future arrangements might be. In terms of availability of staffing, I think we would be able to find staff to do it. There are some specialised roles that are more difficult to staff 7 days a week because the total pool of staff with the right qualifications is smaller, and those relate to specialised testing and things like blood transfusion. But broadly, our view from the lab is that we would be able to provide that extended service was sufficient resource available to pay for the staff.
Thanks very much. Richard, please. Richard Price.
Thank you, Chair. I sympathise with you with the ever ongoing financial challenges, but I share the previous speaker's concerns that this weekend service has been withdrawn. We interpret words in a different way. For example here, during normal working hours. What are normal working hours? Norfolk, particularly coastal Norfolk, has a huge hospitality industry. Very few of those work 9 to 5. We're talking about a culture. I don't know, I've got no medical knowledge at all, but I suspect the busiest time for the NHS is weekends for A&E. They do their very best to cope with that, but Saturdays and Sundays aren't just for going out and having a drink in a hospitality place, or a meal in a hospitality place. Hospitality copes with 7 days being 7 days when business level changes, and Saturday and Sunday are the busiest too. So I think the NHS needs to target that as the end goal and try and take little steps. And when the weekend blood service was introduced, that was a significant little step, and now you're retreating, and I think that's a very regrettable stage. Thank you, Chair.
Thank you very much. Does anybody who hasn't spoken yet wish to ask a question? No? Okay. Thank you. I'm just going to summarise quickly what I picked up. Forgive me if I've missed anything, because I've got a head like cotton wool today. And then we have some recommendations. Is that okay with you? So Stuart started off talking about cost pressures, and he was worried about the degradation of blood samples and concerned about when bloods were going to be tested. Councillor Benbridge wanted her practice to be included in the testing and queried the numbers at the surgeries that were offered on the papers. Alexandra was concerned about patients' need and the proper use of resources and plans for diagnostic centres. Jeanette mentioned that some people have no time off, particularly those who were in poorly paid work, and was very worried that there was no consultation with practices, and asked how we can be sure that this won't happen again. And I did ask, could this be reinstated? Councillor Shires said that changes seem to be happening and challenged healthcare for working-aged adults. She also had a recommendation which I'll bring up at the end, okay? Victoria, the inability of people to get to appointments, and was disappointed that the decision wasn't pre-scrutinised. Lucy Galvin spoke of the impact of transport on health, concern about EQAs and how can we know that they've been done, and asked that these would be pre-scrutinised. Councillor Neil, numbers of staff working on Saturdays, were they the same, and are there problems with getting staff to work at weekends? And Councillor Price was concerned about the service being withdrawn and queried normal working hours and said that the NHS needs to target weekend services. Have I captured? Oh, Leslie, sorry, did I not get you right?
Sorry, Chairman, it wasn't my practice.
Oh, right.
It was a practice that is located in the most deprived area of my division.
Okay.
And that was really because of access, physical access.
Okay, thank you. Alexandra.
Oh, yes, and it was about using the South Lynn Health Hub as a community diagnostic centre, which it's intended for.
Okay, thank you. Oh, sorry, I seem to have got everybody wrong here. I do apologise. Yes, tell me what I did wrong.
You didn't do anything wrong.
Oh, right.
You just omitted. I thought the clinical impact was a very important factor that hadn't been taken into account, and I'd be very grateful if you would note that down.
I will.
Thank you very much.
Thank you. Lucy Galvin, please.
Thank you. Similarly, just an omission, it wasn't that EQAs weren't being done, it was that the process of EQIAs wasn't capturing. So I think you've got it in the words I spoke, which are probably recorded by the Secretary, but if you go on what I said originally,
okay.
It was that the practice needs to be looked at, the actual EQIAs, and the review practice needs to be looked at, and we could pre-scrutinise that here.
Okay, thank you. So we've got two recommendations, I think. One is from Lucy Shires, the wider impact on working-aged adults, and that we look at that. And then Lucy Galvin, I think you've just explained what you would like. Please fire away.
Thank you, yes. So that we look together with Healthwatch at the ICB's work on its EQIAs, what might have slipped through the net if they're not fit for purpose, if they're not picking up impacts on vulnerable populations. And also, I think there was a point raised a couple of times about patient participation that was welcomed to be picked up. So how the ICB actually works with patients and providers, because it was mentioned very clearly that they weren't consulted before that change. So it perhaps is a separate recommendation that we ask the ICB to bring us back a report about how it does that consultation with patients and providers.
Okay, thank
If people are happy with that.
Thank you for that. Richard?
Can I suggest that we as HOSC write to Graham Plant as the cabinet member to ask him to work with the bus companies to carry out a review of current bus travel to health centres and hospitals, and to ask him to ask the bus companies of how they think they can improve that, because obviously that's come out today as being a need that's not being fulfilled. And Norfolk has bucked the trend. We're the only county in the whole of the country where bus use has increased numbers. So we must make sure that that's not just getting into work, but getting into medical services as well.
If the committee agrees, I'd be delighted to. Right. Yes, Councillor Bembridge, you have something?
Thank you, Chairman. There's a new bus route that's been added in my division to go to the new surgery, which was moved from the centre of Kings Lynn. But it's one of those bus routes that if it's not used, it will disappear. And that worries me greatly. I should actually go and use it a lot, shouldn't I? But I rarely go to my surgery. But I could go there and back quite a lot to make sure it is used.
Yeah, you have a quiet life.
I'm in agreement with Richard's suggestion that...
okay.
The letter should say that they should be prioritised and protected.
Thank you. Yes, I do. Thank you. Yeah, Alexandra, please.
Yes, and with reference to that, which is the 3H bus, it actually starts from South Lynn. And unfortunately, County has said it is reviewing that service. And I've said it needs to stay. And I did put out a timetable to every household in South Lynn over the Christmas period. But also a mistake had been made because people were being charged double of what they should. The £1.50 cap wasn't being applied. So instead of a £3 return fare, people were being charged £6. But I've asked County to take that up with the community transport. So I think this is something which the committee perhaps could include in its recommendation, that the buses we've got do need to stay. Thank you.
Thank you. I'm going to ask Becky to go through the recommendations as she's making far more accurate notes about this.
Thank you, Chair. Yeah, obviously we just need to make sure that we're recording what the committee wants to propose and obviously vote on. So, Councillor Shires, your recommendation is that the committee receives a report to scrutinise on the wider impact on working age adults of accessibility to services, and that's a report to scrutinise in committee, just for clarification.
Yeah, absolutely. So we've had many issues come forward since I've been a committee member, and it's all, every time we've raised something about working age people. So I think we need to, whilst they are the majority, not a minority group in some cases, not in North Norfolk, I think, then we need to just make sure that we're not inadvertently making it harder for that population to access. So I would very much like it if as a committee we can look at that. I think it's something that we've had to thread through each and every single one of our meetings.
Thank you. Could I ask, do we have a seconder for that? We'll have Alexandra Kemp as a seconder. Can I have a show of hands, please, those in favour? That's passed. Okay, thank you.
Thank you. So the next recommendation was, and to just clarify the ask here, to look at the ICB's work on equality impact assessments with Health Watch, and also to work with the ICB as part of that pre-scrutiny of any review that the ICB undertakes about its approach to equality impact assessments. Is that what your request was? And is that what the ICB have agreed to, just to clarify the ask.
So, sorry, just to make sure I know what I'm agreeing to. So we will provide you with, we will work with Healthwatch to pull together what we're doing and how, and provide you with a report so you can scrutinise and feedback. Is that, yeah?
Could that be done rather urgently, please, in view of the fact how important those are and how they impact other areas? And could it have a slightly retrospective look back at other EQIAs that might need readjusting in the light of it? Thanks.
Yeah, I've just been advised that we'll be looking at that at the Forward Work programme, so that when it's decided. Okay, could I have a seconder, please, for that? Lucy Shires, can I have a show of hands for those in favour? Thank you.
Thank you. So the third recommendation was to receive a report to scrutinise, which is picking up the approach that the ICB takes to consultation with patients and providers.
Yes?
I guess we could usefully add, particularly when services are going to change.
Okay.
If that's helpful as a focus.
Thank you. Could I have a seconder for that, please? I'll have Paul Neal. And can I have a show of hands, please? Yes, everybody's in favour of that.
Thank you. And the final recommendation was to write to Councillor Plant, the portfolio cabinet member at Norfolk County Council with oversight of transportation, to ask for a review of public transport, specifically bus links, in relation to health services, to ensure that there is provision and the approach taken by the council to ensure that provision is considered.
Do I have a seconder for that? Lucy Galvin. Can I have a show of hands, please, for those in favour? All in favour. Lovely. Thank you very much. Okay, I think that concludes this. Thank you so much, those of you that have been here. And yes, we'll be moving on to the next item. I don't know if anybody wants to leave at this point.
We'll stay for a bit longer if we may.
I'm sorry?
We'd like to stay for a bit longer if we
Oh,
may.
yes, you're really welcome to say. Sorry, I thought that you maybe wanted to leave, so I was going to give you a chance to shuffle away.
If you'll excuse me, Chairman, I will leave. Thank you.
Okay, thank you.
Nice to meet the members.
Thanks very much for coming today. Thank you. Well, strange to say, we're actually on time today, so we're going to turn now to our second substantive item, which is palliative care and end-of-life care, an update. We haven't received any members of the public who've requested to speak on this item. So I'm going to call on Dr. Frankie Swords from the ICB to briefly introduce the report.
Thank you, Chair, and thank you for the opportunity to bring this really, really important area for discussion again. So to start, this is a huge and growing issue. About 1% of our population dies each year, and the people who die are mainly older people with multiple long-term conditions, heart disease, COPD and cancer. So in Norfolk and Waveney, that's around 12,500 deaths. The largest number of those deaths do occur in our hospitals, which we know is frequently not where people, given the choice, would like to receive their end-of-life care. We have got green shoots. We are pleased to see an increasing number of deaths occurring at home or in people's usual place of residence, but that's something that we really want to focus on. So our focus needs to be on upskilling our generalist workforce, so the people who are out there, and integrating the care that they provide better, so there's more joined up care between the generalists, the primary care and district nurses who are really supporting people in their homes, right up to the highly specialist. So that's the first point I wanted to make. We've just completed a review, a very large review, to understand what we have, where it is, how it's paid for, how it is working, and specifically what that means to the people who use it. So specifically using the feedback from the Marie Curie survey. We've found that the provision is not what we want it to be. It is inconsistent. It is very variable, particularly the number of and access to specialist palliative care beds, and it's inequitable. So the more deprived areas often have the worst access to that specialist care. Now, specialist care isn't everything. Generalist care is the majority, but even so. So we've done this large review, and we are now using the findings of this review to agree what we want in the future. So it's clear what we want to be provided and by whom and where. We've just held a big workshop in December to share the review findings, and we're running place-based workshops in February to get provider engagement, so our hospices, our other VCSE organisations, primary care, community care, and our hospitals, to say, come on guys, we want to move to a completely new model of care. We're giving you a heads up now, and we're developing that service specification now with them, and user groups are invited to those local workshops in February. And in the meantime, I hope the paper provides a bit of an update on lots of the things we're doing now to get on with things, because the complete review of the services is going to take a completely new way of commissioning our services and new service specifications is going to take quite a long while. It's going to be over the next year within current contracts, and then it'll be the year after when new contracts can start. So we need to get on with things now. And so the paper summarises some of the work we've done, for example, to improve and standardise the information that patients and carers get, to bring in an electronic palliative care coordination system to tackle the issues we keep seeing on communications and poor integration. And that should be live from April. Lots and lots of specific work on medicines, training for prescribers. There's a lovely dedicated resource now on our Knowledge Now pages. We've introduced kits, so pre-populated templates within the GP electronic systems, so that you can click a box and it says, would you like to add palliative care prescribing to this? Here's a pre-populated thing, just to really make it as easy as possible. We've also added things like the essential medicine service information, which pharmacies carry the extended drugs, what are their opening hours, where's the nearest one to you. We've added that to our yellow folders. We've increased the number of medicines that our out of hours and emergency providers can get hold of. So we've done a whole load on medicines, because that has come out from our service user feedback as not being okay. And finally, workforce. Lots and lots on workforce training and upskilling, so that that generalist workforce knows what to do and are integrated better. So I'll stop there, but very happy to take questions.
Okay, start with Lucy Shires, please.
Thank you. Thank you for the paper. A huge thank you to everybody involved in the end of life care of anybody. It absolutely transforms the way that those that are left here are able to deal with loss, and when it's right, it does make a huge difference. So a huge thank you to everybody that's involved from start to finish, really. I wanted to just highlight the huge gap in the north, which it always feels like we have, and the fantastic Benjamin Court, which still sits empty, has been raised many times in this chamber and chamber in North Norfolk. It's such a huge shame. One of the biggest causes of anxiety that I am aware of from my community is when people are having to choose between taking children to school, going to work and travelling to be with a loved one in their final days. And I think that is more traumatising often than the actual loss itself. So there's a little bit of how do we bring families closer together, which needs to be done. And I would really like that to be part of whatever we do looking forward, is how can we make sure that people can be with their loved ones in their final days, because people aren't having to be transported across the county. So that's one strand I'd like looked at. The other side of it is there's mixed information and feedback from carers. And I know that it's such a huge role to take, to offer somebody dignity and grace, and to do that with compassion, and it must be quite difficult for our carers, if I'm honest. I don't think I could do it. As compassionate as I am, I think I would be in floods of tears all the time. So I'd really like to know what's in there to create consistency for our carers and the standard of care that we're expecting, what support's there, and when we're actually going to... When the biggest issue that we have is care isn't seen as being as important as health professionals, and I think we need to make that so. So how are we going to enable our carers to feel like they're part of the healthcare system and raising the standard of that when it comes to palliative care?
Thank you. Yes, please answer.
Could I just check that I'm understanding you correctly? Are you talking about informal carers, so family carers, friends? Okay. There are, I think, perhaps two strands to this. On the one hand, we are enormously reliant and enormously grateful to carers. And so some of the work we've done over the last couple of years, for example, introducing the carers passport, and so to really make sure that carers are recognised and empowered and allowed to enter the ward and join in on the ward round, for example, when somebody's in hospital, but equally recognised when a person is going into a GP surgery that this person is very, very important and should be listened to very much as part of the conversation. And that's broader, that's not just in end-of-life care. So there is a larger piece of work on carers. In terms of this piece of work, so we have invited carers as well as service users, so that's people who are dying, carers and bereaved people to the workshops to make sure that we get their voice heard, but they are included in the training programme that we're rolling out. And in terms of the formal carers and caregivers, the training we've done has focused on what I think are the two of the most difficult areas to have those conversations. So those are people with learning difficulties and dementia through something called our No Barriers Here training, because we need to talk about death more. We need to anticipate, we need to have those conversations much earlier, but they're difficult, as you say, quite challenging conversations. So the No Barriers Here training is to really upskill people, and particularly our nursing profession, to start those conversations and hold them well. And the second really difficult area is in children and young people. We don't like to face that it's coming. And so we've with the support of East Anglian Children's Hospice, we've rolled out specific training to have those conversations with young people and their families, because it's another huge area. And if we don't start talking about it, we can't plan and we can't engage them, we can't empower them.
Thank you. I'm just going to ask a question here. This came up when I was first on HOSC 1,000 years ago, palliative care. And one of the people who I spoke with at the time, his wife was dying, and she wanted to be at home. And one of the problems was, and this is a very basic problem, but she was fecally incontinent, and she would be put in pads at 5 at night, and then they wouldn't come until 9 the next morning. And she wanted to be with her husband, but she was so embarrassed by how she smelt and didn't want him to have to be the person to care for her. And I do understand the importance of medicine and other things, but there also needs to be really good, intimate, personal care offered to people, because you only get one chance to have a good death, don't you? And you know, I suppose as a former nurse, I think this is an area that is so important. And is that something that's being considered so that other people aren't having to face that?
Thank you, and I couldn't agree more. It's sometimes the basics that make the biggest difference. And I would also echo your comment that most people don't want to die in a hospital, and the number of people dying in a hospice is tiny. Most people want to die where they live, so whether that's their home or their residential home. And so we need to make sure that the support is there so they can, and so that they and their families, friends and carers aren't panicking because they don't know how to get support to enable that good death at home. Night sitting service is one example of which I think would tackle the issue you're talking about, Chair. So we have a night sitting service in West Norfolk, and we don't have it anywhere else at the moment. And so that's just one example of the variation that we found. And actually, we need to get the basics right everywhere.
Thanks for your answer. Alexandra, please.
Thank you, Chair. I was privileged to be able to look after my mum at home in the last few months of her life, and we're very grateful to the support from the Marie Curie service and the district nurse. But obviously, a lot of people in a position where they need to go into a care home or a hospital or a hospice. And looking at the figures on page 48, we have a huge shortfall of the specialist beds, which we should have. We've got 22, but we should have, and you've calculated it either as 67 or 49. So we have a shortfall of between 27 and 45 beds, which is quite a lot. And also, looking at the page which shows the number of specialists we should have, we have a shortfall of up to 5 full-time hospital consultants. So how are you looking to provide the resources that we need, and also equitable access across the county? Because I'm very mindful that the hospice in West Norfolk has to do a lot of fundraising, a huge amount. It doesn't have the funding which some of the other hospices have. So those 3 points, I'd be really grateful to hear what your plans are.
Thank you. And each hospice is very different, and whether or not a hospice bed fulfills the criteria of being a specialist bed or not is quite regulated, and it really depends on specialist palliative care and often consultant access, and that is very variable. So the first thing we want to do is maximise what we have already. So we have very generous provision in some areas and very poor provision in others. So we are having conversations with the providers of those care at the moment to say, how can we even this out? So maximising what we've got before actually saying, and what else do we need? And so I'm very hopeful that we will be having a new hospice in Yarmouth, for example. I can't remember the exact timescale, but obviously St Liz has been doing a lot of work, and we're very supportive of that, and that will make a huge difference. We're anticipating a small number of beds coming online soon, and then more beds coming in time. But I mentioned that the current contracts run for another year, so we have to work within them. So getting more out of what we're currently getting, and then before we completely change the service the year after.
Thank you. Deborah, please.
Thank you very much, and thanks for your responses so far and some of the comments. I'm quite interested in whether the work you've done or will do will take into account the potential savings for doing this right. Because if you provide the sort of care that Brenda was describing, or somebody's allowed to remain at home for longer, they're not in hospital, taking up a hospital bed. And I just wonder what the figures look like, and whether you'll be working those in.
Yes, is the short answer. We are very aware. The total amount of spend at the moment is enormous, but we're not spending it very wisely. We're spending it in emergency care and sometimes repeated admissions for somebody within the last year of life, whereas actually if we got our heads together and planned more effectively with that patient and their family, put something in place proactively, we would avoid those 3 admissions that would have really added nothing but upset and travel, as your colleague mentioned earlier on. There is another real issue with the provision of what's called fast track. It isn't terribly fast some of the time, but fast track care, which is where somebody is identified as being likely very near the end of their life. And so a sort of an emergency package is put in, and then a few weeks later you realise actually this person isn't end of life. You really ought to have done it in a different way. And so there's significant savings to be had through both of those areas, which we want to put back in. And this is something that we really want to make a bit of a flagship of the new Norfolk and Suffolk ICB to really improve palliative care across the whole of both counties.
Sorry, Chair, will you be bringing back some numbers of what's actually involved in those figures?
They are included in the paper, in the appendix of the paper, and I'll try and find the actual number for you because I will find it in a mo. I think it's 28 million, but I can't quite remember. I can't.
Do you want to come back to us on that, and I can distribute it to people? Is that all right with you, Deborah? Yeah, thanks very much.
32,799,000 is what we currently spend within our block contracts on the entirety of palliative care. So there's a lot in there. We need to pull it out and put it in the right places.
Thank you. Stuart, please.
Yes, thank you, Chair. And for full disclosure, I will draw reference to my register of interest where I actually am an employee of Norfolk Citizens Advice, because this report does mention around access to money and benefits advice, etc. However, my comments aren't in relation to that. First of all, I just want to say that in my year as chair of the county, I had significant exposure to the wonderful people that work in palliative care across our county, the butterfly volunteers at the NNH and various hospices, and my hat goes off to them. They do the most difficult job day in, day out. But we are talking around investment and consistency here as well. I guess the key thing for me is around this is that I welcome the drive to make this consistent across Norfolk and Suffolk, but there are within the report quite clearly marked differences, and I found it alarming that almost a quarter of the people were saying that actually they didn't get good service. Now that's not a good place to be when we're talking around this. In a previous role, I was a senior identification manager around disaster victim identification, working at the coroner, and one of the tenets through that, and it's stuck with me to this day, is the mark of a civilised society is the dignity it affords its dead. And I think that can be extended in this space to those who are dying. And I welcome the drive to get this right, but with all of the other demands on the ICB, this needs to be done at pace, with vigour and with investment for those people that are the staff, the volunteers, the patients and the families. Because although significant investment, 32 million, sounds a lot. In reality, when you look at the breakdown on page 43 per patient, it's around about £2,500 per patient. Now that is the equivalent for us as councillors of the average Band D property tax for 1 year in Norfolk. And I'd question whether that is enough investment in those people, those families, in their last year of their long, hopefully long, but sometimes permanently cut short lives. So can we have a look at the investment, and can we do this quickly, please? Thank you.
Will you bring that forward as a recommendation? Oh, no, I beg your pardon, sorry. Victoria Holliday, please.
Thank you, Chair. I have 3 questions. First, can we be assured that the findings of the Marie Curie review were a front and centre of your implementation? That's the poorly performing for fair access to care and coordination of care. I think you've mentioned it today, but it doesn't come through very strongly in your review paper. So that's question 1. Question 2, are you considering out of hours as a stakeholder? Because I understand that they are very involved in end-of-life care and perhaps in very precarious circumstances, and I'd like to know that their voice is being heard. And also, are you looking elsewhere further than Suffolk, for example, other geographically similar areas like Cornwall, for example, for benchmarking and best practice in end-of-life care? I'm sure Suffolk's absolutely brilliant, but there may be other areas where we could also learn and improve our care. Thank you very much.
Excuse me, could you just give me your first question again?
But can we be assured that the findings of the Marie Curie review are front and centre of the ICB's review and further work on end-of-life care? Thank you.
Thank you. So the answer to your first question is yes. The initial draft of this paper was 75 pages long. I thought it was a bit too much for OSC, so we've cut it down. But so I'm sorry if it doesn't come across as loudly within that. But absolutely, the Marie Curie findings, while 55% had good care, 22% had poor care, as your colleague pointed out. So they are absolutely included. Secondly, in terms of out of hours, they ought to be, but I'm not certain that the out-of-hours providers have been invited to the specific workshops, but they have, and so I'll make sure that they are. But they have absolutely been included so far in the general planning work, and one of the proposals that we're hoping to go live with imminently is actually getting palliative care input to our unscheduled care coordination hub, which is the way in which people who've called 999 or 111 are often reviewed in real time by a GP, a paramedic, a team. And so we're hoping to get specialist palliative care in there as well, because a lot of those calls and a lot of people who need help with their palliative care really run into trouble at 2 a.m. and so where do they lean? And the third question was
benchmarking and best practice in other geographically similar areas, not necessarily Suffolk. Thank you.
I'm not certain whether we've done that, so I'll make sure that we do. But yeah, we often look at the West Country because they have so many similarities to us, but I'm not certain we've done that, so I'll make sure that we do.
Thank you. John Fisher, please.
Thank you, Chairman. I think previous speakers have identified what a difficult subject this is, and just I think one of the things that I would like us to consider is the difficulty and the impact that palliative care, end-of-life care has, and the whole end-of-life scenario has on both patient and carers. And I understand that there are trials going on at the minute for drug trials to assist with removing or dealing with the depression and anxiety created for both the patient and the carers. And I just wonder whether the ICB or NSFT should in fact be considering. I know they're looking for trusts to be involved with trial drug testing and this sort of thing, and I wonder if this is something that maybe we should consider, either ICB or NSFT. Thank you.
Thank you. Actually, I think the NNN are already involved. So the palliative care team at the Norfolk and Norwich, one of the members of that team has actually just led a project on removing the access to research for people who are end of life, because most trials are done in men and working age men to boot, and so there are huge chunks of our community for whom we have very little evidence. For example, the people who are over 80, there's very little evidence of whether the drugs work or not in people who are over 80 because they weren't included in the trial in the first place. And people who are approaching end of life have traditionally been excluded from trials. Too difficult. How are you going to start that conversation? But that's not okay. So actually, Dr. Caroline Barry, who's one of the palliative care physicians at the NNN, has actually literally just led a piece of work to say, how can we overcome that barrier? How can we go through an appropriate consent process with people who are end of life and their carers, because we need evidence and we need to do that. So I'm pretty sure they're involved already, but we are always very keen to support research. We're one of the most research active ITBs in the country, so absolutely.
No, thank you. I know that I think it's the Doncaster and South Humberside NSFT, or not the NSFT up there, have in fact just recently taken part or are taking part with a drug trial. Thank you.
Thank you. Lucy Galvin, please.
Thank you. Thank you for the report, and it's good to hear the work going on in this area. I just wanted to ask really about the assisted dying bill. I know it's mentioned in the report that the impacts of that are being scoped. It's not clear yet what the full impacts of it will be, because I think the bill isn't quite through yet. But and to caution really that against this idea that a lot of money will be saved in this area, and I hope that's not the kind of thrust of it's great to hear the ICB are putting this front and centre and seeing it as a flagship, but not a flagship for money saving. Really, it shouldn't be, because in fact it probably needs that investment in the future to make sure we can respond to the changing culture around this area and provide a really good service. As you said, I just wanted to check with the sense check that with you, really. Thank you.
Absolutely 100%. And I apologise if I didn't make that clear. But I think what's telling is how much money we are spending, and spending badly. If we spent that money in a proactive way, involving patients and their carers to really say, well, what matters to you? So the evidence from the electronic palliative care record rollout that's previously been done in North East Essex, it's just going live in Suffolk, about to go live in Norfolk from April. Actually, when you involve people, when you listen to them, when you make it easy to communicate, and so that every paramedic, every out-of-hours GP, everybody involved in the wider care can see easily what that person wanted and what they've already agreed with the district nurse with whom they have a really good relationship, makes a huge difference. And we can provide a better service. But does that mean we won't need to invest as well? Oh, I'm certain we're going to need to invest as well.
Thank you. Jeanette, after Jeanette, does anybody else have a question? Lucy Shires and Leslie Bembridge. Okay, so Jeanette, please.
Thank you, Chair. It's brilliant that you're planning extensive training for people involved in end-of-life care. Can I just ask how you're going to ensure that that training is delivered well, with rigorous kind of assessment ongoing? I attended some health-related training last year, which was appalling. And it was delivered by 2 organisations with good reputations. Everybody who was there agreed that it was just a complete waste of time and money. So I think it's important that if you are delivering a lot of training and development, it does need to be good.
Yes, it does. If you wanted to let me know what that training was in case I can do anything about it, I would always hope that we're training to improve people's understanding so that they can improve the care they give. We need to feed back if that is not delivering, and so we need to let them know actually that didn't land. And every time I attend a training session, there's nearly always a feedback at the end to say, how could I make this better? But I hope and I'm pretty confident that the training we give uses the feedback, evolves, and is, does what it's there for.
Yeah, I did feed it back, but I know that it is important when you've got different groups delivering training that it is consistent across the board.
Thank you. Councillor Shires, please.
Thank you. The perils of speaking first are that you don't get to listen to everybody and what everybody else is thinking. I think it's been a really valuable discussion, but reflecting on what Councillor Dark had talked about and we've all spoken about as the dignity in dying, and it's the one thing that everybody in this room is really got in common. We're all going to get there at some point. So I think, whilst I understand it's going to be a really big piece of work, and it feels like it's expensive when it really isn't when you look at the figures. I think there are 4 things that I would like to propose, and I know that this is going to be a lot of work for you in general, but I feel like it would really help put our minds at rest a little bit if we could have some more information as this progresses. So we've spoken about the gap in the hospice beds, and I think it would be beneficial for us to have an expansion plan. We know that it's not going to happen all at once, and we know it's going to be phased, but to actually understand what the site options are, the workplace implications, and the implementation timeline is going to be across the next couple of years, so that we've got a good grasp on helping you steer. I think we've spoken about carers, and carers are often spoken about in this chamber, actually. So a carer support mandate, I think, would be really helpful, so that we can help you track where carers are getting the adequate support and not. And part of that would be metrics to respite access, training, bereavement support, uptake, and general well-being measurements. I think that would be beneficial, and that would help us make sure that the people that left behind are actually not left behind in a terrible place. So that's the second thing, that hospice at home hours delivered, and the core 20+ outcomes, and any action that needs to be taken to correct those, because this is such a big piece. And I hope that those 4 recommendations would help steer you in what I think as a committee would be really useful. I can email those over to Becky quickly if that would be helpful.
I think that would be enormously helpful. And
I'll do that right now.
That would be as a briefing note, wouldn't it? Yeah, okay. Thanks very much. Thanks, Lucy. The next person I have is Leslie Bembridge, please.
Thank you, Chairman. You started off by mentioning somebody who had a very undignified death, and that could have been my mother. She was put on the Liverpool Care programme, which I don't think exists anymore, but took 5 weeks to die. She was very determined to find out what the result of my election campaign was, and then she died that night. But it was awful, absolutely dreadful. But I would like to say that things have improved at the Queen Elizabeth Hospital, because I do quality assurance reviews, and I've been on wards where people are dying. Most they have cancer, but they're not. But they are at different levels, and so I've been able to chat to some of the patients and chat to family members, and it seems very improved. And the Queen Elizabeth Hospital has opened up Pedder's Way, which is for end of life. So I don't know whether that's what you were referring to, Dr. Swords, when you said about the West having some care, because it's a lovely unit, and it would be a much better way to die. I'm going to put my name down in case. But I really wanted to ask about the funding for that unit. I mean, does it come out of, say, hospice funding, because it's like a hospice? But also, you mentioned night sitting service. And is that in hospitals, or is it at home? It's at home. Because quite frankly, some of it could be used in hospitals. So really it's about, does the funding get taken from a hospice type funding for the Pedder's Way? And you mentioned that you're looking at possibly doing similar work in other hospitals. So would that be from the hospital's budget? Or yeah, it is, right, okay.
So sorry, if I may. So those sorts of developments are within the hospitals, and it's within the hospital's budget, so it wouldn't be taken away from a hospice. The way in which our hospitals are funded at the moment, although it may well be changing, is through a block contract. So they are given a defined amount of money from which they organise all of their services. And so for an individual hospital, if they find that one of their services isn't working very well in the way they do it now, if they can find a better way of doing it and a more compassionate way of doing it and more efficient, even better, they would do that within their block contract, so it wouldn't have any impact on the hospice funding. And night setting is something specifically for people at home, because although I know your colleague asked about an expansion of hospice beds, but actually the move in the hospice movement is generally that we want more care at home, and we want hospice support for people at home. And so night sitting is one example of that. Actually, most people would prefer to be at home. So we've got to really see what else we can do to provide the level of care that you would get at a hospice, perhaps in your home.
Could I just ask a supplementary? I sat with my sister-in-law for the last few weeks of her life, along with my brother, and she had a night sitting service through Marie Curie, and it was absolutely fantastic. But so is it just for cancer patients, the night sitting service, or is it for people like my mother, who's 92, come to the end of her life? And I did want to take her home, but I was told she would die in the ambulance, and she would have done because she died that morning or that day. But is it available for non-cancer patients?
At the moment, it is barely available at all. But palliative care is not just about cancer. And as I said at the beginning, the majority of people, so 1% of our population die, and most of them die because they are older and they have multiple long-term conditions, and cancer is one part of that. It is not, everybody doesn't die of cancer. But sometimes you would think so from the way it's portrayed in the media. So actually we want to make sure our palliative care is available for people dying of any reason, heart failure, kidney disease. That's far commoner, in fact.
Thank you very much, and thank you for the good report.
Finally, the very patient Paul Neal.
I was the last one to ask on patient. I'd just like to thank Stuart for bringing up the point about dignity in end of life as well as death. That's very important compared to the old days. One very small thing, just trying to get some idea on this. It seems very odd. Syringe pump tracking. Is it a case of we need more, or we just don't know where they are? Is it that simple? And there, I've got another question. But
syringe pumps are a gadget which enables you to have the medication sort of trickled in, and they're really fantastic in palliative care. And the great mystery of the disappearing syringe pumps is something that goes on and on. Just as recently, we've done some rather wonderful work in partnership with VCSE, the prison, and the council about recycling walking aids. It's really important we recycle syringe pumps because they are really, really vital, but they get put in drawers and forgotten about. So if you track them and collect them, that just means you've got so many more in the system. It's a practical point, but it's actually really important.
it seems like a simple problem to try and solve. Anyhow, the other one, which is a bit difficult to quantify, elective end of life, which is slowly passing through Parliament, so we don't know where that's going to end. But is that something that you've taken into account in the report? Because there's going to be, times when whoever is giving the advice needs to manage the expectations in this sort of period of limbo.
So a few council members have mentioned the assisted dying bill. This will be, assuming it does go through, this will be a significant change, but we don't know what it's going to look like. We don't know when it's going to come in or how it's going to come in. So although we are sighted and keeping a watching eye, our priority now is getting our current services better. And so while things may well change if and when that comes in, we don't know how, we don't know what it's going to mean. So it's not a big factor in our planning at the moment.
Does anybody else have a question? Okay, I'm going to try and summarise. Stop me if I get it wrong, please. Lucy Shires mentioned Benjamin Court. How do we bring families closer? And some people have to sort of transport themselves across the county. Spoke about mixed feedback and the need for consistency and to enable carers to feel part of the palliative care team. I asked about intimate personal care offered, and that should be offered 24 hours a day. Alexandra spoke of the shortfall of specialist beds and consultants, and how can you ensure equitable access to services. Deborah Sachs spoke of figures for savings by keeping people out of hospital and at home. Councillor Dark spoke of the excellence of care offered by staff working in palliative care, but he was alarmed by the lack of consistency and that change needs to be done at pace. And he also questioned the amount of investment. Victoria Holiday asked for, I can't even read my writing, I do beg your pardon, assured the findings of home care are at the front and centre of any future plans, looked at considering out of hours and looked to other areas for benchmarking. Has that basically summed up what you said, Victoria?
It's brilliant, but it was Marie Curie rather than home care. Thank you very much.
Marie Curie, yeah, thank you. John Fisher, impact at the end of life care on families and on the individuals, and spoke about a trial of drug testing to help people's anxiety and depression. Lucy Galvin asked about the assisted dying bill and was worried that money being saved was a prime motivator. Jeanette, how can you ensure that training offered to staff will be of a good standard, because she had experience of bad training? Haven't we all? Lucy Shires, second time round, asked for more information over the next couple of years on the provision of care and carers support and assisted dying, and for figures across the board. At the end, I'll turn to Becky, who will look at this, because it's not a recommendation, but it's for a note. Leslie Bembridge said that things at QEH have improved, asked where funding for the Pedders Way comes from, spoke about night sitting and asked if that was just for at home or in hospital as well, and also asked if night sitting was just available for cancer patients and not people with other conditions. And Paul Neal spoke of dignity at the end of life and syringe pump tracking and elective end-of-life bill, which I think he meant the assisted dying bill, and is that taken into account? Have I summarised what people said? I don't think anybody said anything else. Okay, I'm just going to turn to Becky for this business about the note.
Thank you, Chair. Yeah, so I just want to make sure again that committee know what it is, what they're voting on or agreeing to, and also what the request is. So obviously, committee has various options. The formal option is whether they want to make any formal recommendations to the ICB. So that's one option. The other is to obviously ask for reports, which you did in the previous item, or to ask for briefings and information. So they're the three key areas. Councillor Shires, you've asked for some information to be provided, but you've also got, it appears you've got some requests of the ICB. So I just want to clarify what's a request, what's a recommendation to the Integrated Care Board, and what's a request for information to be received by the committee. I hope that's okay to be clear on that.
So the hospice bed expansion plan, that's something that we need the information of, because that's been raised here, and what the plan is for the closing of the gap there. I guess the carers support mandate and the equity and rural access dashboard is possibly a way that we would like to receive information about where we are. So I'm going to guess that the information that we receive to help is going to help the ICB as well. It's not just going to be that it's something we would like to see. I think it would help the ICB close the gaps on rurality and make sure that the support that is offered to carers is full and rounded. The piece on the voluntary sector would be a recommendation for the ICB that work is done to make sure that the voluntary sector helps co-produce anything to do with the assisted dying bill. So some information back for us so that we know what the plan is to close the gap. Two ways that I think we'd like to receive information to make sure that the points that we've picked up today, we have data to back up any further questioning, and that the voluntary sector is included in co-producing any work on the assisted dying bill with the ICB. So 3 is the ICB recommendation, 1 2 and 4 are the format in which I think receiving information would be beneficial.
Fire away.
Okay, so taking those as two separate items, so one is a recommendation for the committee to consider. So if I just read out what the proposal is for that, the recommendation, and that is for the ICB to work with VCSE partners in understanding how they're preparing for the assisted dying bill and co-producing and adapting the work with those groups. So that's the proposal of the recommendation to formally put to the Integrated Care Board Chair.
Could we have a seconder for that, please? Alexandra Kemp, second. Can I have a show of hands, please? Yes, that's passed. Thank you.
And then, to be clear, for the committee to vote on is a request for further information, as we said, on the hospice bed expansion plan. Further details essentially from the ICB for the committee's consideration, including the site options, workforce implications. So deep level of information regarding that plan to provide those hospice beds. Then there is information for the committee regarding the assistance that is available for carers through who are going through the palliative care process, and with a suggestion of a way of working forwards and how to receive that to be proposed to the ICB. And finally, place level data on preferred place of death, out of hours response times, hospice home hours delivered, the core 20+5 outcomes, corrective action plans. So to summarise, high level detailed information to be provided and requested from the ICB for the committee, with a particular view to equity and rural access, and with suggestions on how that can be put to the committee. There's lots of questions, Chair.
What do you want to ask first? Frankie?
Two things. That the first recommendation that we work with VCSE on the assisted dying bill, the assisting dying, I'd just quite like to get a feel for the timescale because it hasn't been passed. We can't plan for something that we don't know what it is yet. So sort of if and when, if we could, it would be useful to have a steer because it's not something we could or should be doing until we know what the assisted dying bill is going to mean, I think. And then my second point was we do have a palliative care dashboard that looks at the geography, so we can share that.
Yeah, I completely understand about the assisted dying bill. That really needs to be on a sort of back burner, really, doesn't it? Yeah. Yeah, thank you. Stuart, please.
Yeah, thank you, Chair. And it just follows up on my comments around really welcoming this, but with vim and vigour, is can we set a time frame for that report being brought back in relation to what is the plan around palliative beds, etc. And it needs to be in agreement with Frankie and the ICB around, we want it to be sufficiently far out that you can give us some meaningful information. But at the same time, I do feel that I want to put your feet to the fire, that it's not so far out that we're actually, wondering what's happening with this. So if we could come up with whether it's 3 months, 6 months, and get that nailed down, that report is coming back to us, that would be really helpful.
Frankie, what do you think? How close to the fire are you?
I promise I'm close to the fire already. And this is, as I said, our Chief Executive is really keen to make this a sort of a flagship programme for our new ICB that starts in April. So bearing in mind the new ICB starts in April, I would say 6 months from now, 3 months from now, we're literally just going to be forming. So
6 months from now?
At the minimum.
Yeah,
but,
minimum. Yeah, thank you. Is that okay with you? Yes, please.
Sorry, can we just clarify that the hospice bed expansion includes hospice at home beds? Because I think they're incredibly important. Thank you.
Yeah, I'm interpreting the ask as the whole hospice care because, as I say, nationally the move is not to expand the number of hospice beds. Now, we do need a few more, but actually the hospice movement across the UK is telling us we should have more hospice at home, we should have more support at home. So, yeah.
Lucy, read the assisted dying bill. That really does have to go onto a back burner because there's not much we can do before.
No, absolutely. But if the intent is to work with VCSE, then that's the first step in it. Because we've heard today how potentially there's a little bit of co-production that's been missed along the way. So if the commitment is to work with, then I'm happy for that to be said in the chamber. And then upon it being finalised, completed, the plan already needs to be in place as to how you're going to do that, rather than it be one of those things that while you're trying to sort out 2 ICBs and create improvement, I wouldn't want it to slip because there are other things that you're doing.
And so the series of workshops that we've got lined up in February do already include the VCSE sector, obviously, and the hospices. So yes, that's business as usual.
Are people happy with what's been proposed and what's been received? And can I have a seconder, please? Thank you, Alexandra. And can I have a show of hands, please? Lovely, thank you. Just 1 second. Okay, thank you. Thanks, everybody, for your input to this difficult subject, and thanks very much for the areas of concern that you've brought up. And thank you, Frankie, for facing all of us here today. I'm going to suggest now that we have a break. I have 10 minutes to 12, so five minutes past 12. Would people please come back? Thank you. We're now going to turn to our third substantive item on today's agenda, which is Norfolk Medicine Support Service. We haven't received any members of the public who've requested to speak, so I'm going to hand over to Dr. Frankie Swords from the ICB to briefly introduce the report. Thank you.
Thank you. So the Norfolk Medicine Support Service was something that was commissioned back in 2003, and it hasn't really changed since. It exists with very worthy aims. There are three parts of it: to assess individuals and make a recommendation on what support they might need, to provide a compliance aid to help them with their medication, and or an administration chart to keep a track of whether they've taken the medication or not, and previously also to provide some training, although that does seem to have slipped away. That doesn't seem to happen very much over the years. We have reviewed the service, and we've found that it's not really fit for purpose. It is outdated in the model, it's quite paternalistic, it's not integrated into the rest of our healthcare system, and it's not really in line with our modern care principles, really about empowering people and making sure things are local and close to home where possible. So the service, the funding for the service has also been pulled by the council, and we're intending to close it from an ICB perspective as well in a few months. So we are currently in the midst of creating a transition plan, both with patients themselves, the current providers, and primary care, and when I say primary care, I mean broader primary care as well, this community pharmacy as well. And the intention is that every existing patient who's currently supported by the service will be offered an individual structured medication review to work out, are they on what they need to be, is it done in the best way, then to assess their needs. Actually, is a Dosset box, for example, really the right thing for this person, or would it be better? Would they be better supported in other ways? They'll also assess their eligibility for other support, including compliance aids. And these days, we can have home delivery of medication. We can have home delivery of compliance aids as well, which can be done nationally and remotely. So that's the sort of overall plan for the existing patients. New patients, we are developing a resource pack to support primary care to assess people who they would previously have referred to this service, to assess their needs and support them. And the MAR charts bit, so that's the medication administration record charts, will become the responsibility of the home care providers. So that's sort of a very headline what we are expecting to do, but the detailed transition plan and the individual transition plans are live. They're still being developed and developed with the users themselves, and I expect that will go on for the next few months.
Thank you for that. Members, do you have any questions, please? Lucy Galvin. Anybody else will have a question? Lucy Stewart. Anyone else?
Thank you for the report and for bringing this in advance of the closure. I note that there's a demonstrated high level of satisfaction for patients, but patients haven't they don't seem to have been asked about the closure. I am, from a bit of research, it's generally for some patients that can't manage their meds as they have conditions that prevent them from managing it, like maybe dementia or forgetful. And they haven't got anyone that can support them, so they set up a Dosset box, as you say. For instance, an elderly person could be taking 10 different kinds of meds at different times, or some patients can't read and write, and they have. And there will always be those people, won't there? So it's a significant need. I wanted to ask, has inequalities in EQA been done on this decision? I can see the service isn't right, but the need is still there. And so there's one question is about the EQA, and the second one, I think you answered about the patients in the future, but how will you assess, or have you risk assessed this in terms of more hospital admissions, for example, because there has to be something in place in this area, because lots of people don't have relatives helping them, etc. And it seems that there's quite a high risk in stopping the service, and how's that being mitigated?
Thank you. So that is exactly what we're trying to mitigate through the transition plan. These people need support. And so what's the best way to support them? And our overwhelming feedback so far is that it needs to be individualised. And that's not necessarily what they're getting at the moment. But just to give a bit of broader context, this doesn't exist for Waveney and it doesn't exist for Suffolk. In fact, most of the country, this doesn't exist because it's quite an old-fashioned and sort of rather outmoded model. Other things do exist there. The need still exists, but there are better ways of meeting it. So, for example, a structured medication review to go through with the patient and or their carer to say, actually, do you really need all of these medications? You mentioned some people being on more than 10, some people are on more than 15, and the risk of hospital admission and side effects as a consequence of a very high, we call it polypharmacy, when people are on lots and lots of tablets, is huge. So that's step one. Have they really had a proper review? And we're incentivising that in our prescribing quality scheme. And then if you do need multiple medications, it is difficult to keep track. It's difficult for anybody to keep track on them. But dossett boxes themselves are quite risky. So we know that some people can't. You mentioned that the reason some people use this support service is because they perhaps have difficulty reading, but others have difficulty opening the packets. And if you have a dossett box, it's even more difficult to open the packet. And when you open it, everything jumps up and then lands in the wrong box anyway. So they're not the answer to everybody. They are very useful for some people, but actually supporting people to know what their medications are, what the pink one's for, what the blue one's for. When you take the little round one, is actually much better in terms of reducing their risk. So, yeah, there's definitely a need, and that individualised planning is key, really, and that's what our transition process. But we're quite keen to have input into what else you think we should do to do this safely.
So I guess it's just like to see that risk assessment of how many more admissions there might be, and to see the EQIA would be useful on this as a standard procedure. It sounds like to make sure that the structured medication reviews do take place. How can we? It's incentivised, but do they definitely happen? I mean, yeah, I'm not familiar with what really needs to happen to make sure it is okay, but it's clear there's a whole set of things that would need to be brought in to replace it before when you stop something.
Yeah, thank you, Chair. Committee members and councillors will know that quite often I'm vague by accident, but I'm going to be trying to be vague by design around this because it's around finances and the contracts. It's just on page 84. I just want to get some reassurance around this because second paragraph down, the ICB has taken a decision to stop the contract when it expires on the 31st March 2026. The paragraph above it says that Norfolk County Council will cease funding after April 2026-27 at the end of that period. So potentially, does it mean that Norfolk County Council is funding something for a service that's already stopped?
I'm sorry, the paper isn't as clear as it should be. We're being a bit vague, aren't we? Norfolk County Council has given us notice that the funding stops at the end of March this year. Which was actually part of the trigger for us to say we really need to look at this whole service.
Thank you. Richard, please.
Thank you, Chair. I wasn't aware this service was available. I have an eye condition called glaucoma. I've had it for 35 years. I now have 5 different eye drops, which I administer once, twice or 3 times a day to one or both eyes. I'm in my mid-70s. My fingers don't work as well. Each different eye drop is in a different bottle with a different firmness. Each liquid has a different viscosity. And it's very easy to miss and have a failure rate. But I have a good relationship with my consultant, my doctor, and the pharmacist at my local surgery. And so as the need has arisen, I've been able to adjust the quantity of each medication as needed, because when you have something like glaucoma, if you don't take your eye drops, you go blind. And it's a bit like an asthma sufferer. If you haven't got a spare inhaler, you worry what would happen if that one runs out or you lose it. So it's a good GP surgery, a good consultant. You don't need this service.
And if I may, eye drops are a good example that aren't included. And things like insulin not included because they tie with a meal or different times of day, they don't fit in the boxes. So, yeah.
Thank you. Can I just confirm I've got Victoria and then I've got John Fisher. Anybody else? Jeanette? Alex? Anyone else? Okay. Sorry, we'll go with Victoria next, please, then John. Thanks.
Thank you, Chair. I always thought these were brilliant, actually, from my first days on the PCT in about 1850. And I know that's very old-fashioned, but to me, it's compliance. I mean, I thought the structured medicine reviews were independent of this. I was hoping that everybody would get a structured medicine review annually. And so this isn't as if you're going to be the carrot for getting this decrease in service is to get something you'd be getting anyway. This is all about whether you're going to take the medicines or not. And as we are increasingly older and frailer and more independent, because that's the direction of travel, and these are all very good things, we need all the help we can get. And it's not just MAR charts, if I remember. There were some other devices that people had to help them remember to take their medications. So I'm disappointed, and I'm disappointed that there's no equality impact assessment or no real clinical risk assessment here. And there's quite an emphasis on the negatives of this and not enough emphasis on the positives. So I'm very glad, again, we're seeing it, this is a pre-scrutiny item, because I think it would be very sad to see this in retard, I must say, as an item that had happened already. So I'm not 100% comfortable with it, and I think I need more evidence that this is the right thing to do. Thank you.
We have conducted those impact assessments, we just haven't brought them all here. So there's quite a big programme and there's a steering group working on the transition plan. But just to provide you some assurance that that has been undertaken. And again, most places don't have this anymore. Most of these have closed, and there isn't one for Waveney and there isn't one for Suffolk. So it is popular with people who use it, but it is of its time, and most people do it in a different way now. So that's what we're wanting to transition to.
Okay, can I just come back on that? I mean, I don't think that's, just because we're different isn't a bad thing. It's a very good thing that Norfolk's different, and perhaps our population is slightly different. Can we see some details of these transition plans, actually? Because otherwise I'm concerned that people who are depending on these to take their medicines regularly are going to be lost. And I know there's all these community teams that are going to be coming around to help them, but I'd like evidence that this is actually going to happen. So perhaps we could have offline some sight of these transition plans in more detail. I don't know what our colleagues feel about that. Thank you.
Is that possible, Frankie, please?
Yes, the only thing I'd say is the transition plan is evolving every day. So we are continuing to work, and there were some issues actually getting hold of the names of the people who actually use the service. So we need to know exactly who they are, and we need to assess them individually. So the plan is going to change as we find more people within it. So which is part of the problem, because it's completely in isolation. So yes, we're happy to share, but it is changing and evolving all the time.
Could we maybe have an outline of the plan?
In more detail than is in this? Yes.
That would be helpful, wouldn't it, members? I think if we could have sight of that. Deborah.
I'll just go back to the original contribution, which was summarised in, you need a GP that is on the ball and does a regular review. I mean, my mum had one of these set boxes, and it was great until it wasn't. And then in the final months of her life, I've just found the photographs of what we were trying to work out what on earth she was on. And actually the information was partly there, partly not. We had no idea. She was confused. The system fell apart, and there wasn't a way of monitoring it. This wasn't in Norfolk. So, you know, the basic service of prescribing and reviewing regularly has got to be there, and there's no substitutes.
Thank you. John Fisher, please.
Thank you. I actually welcome this, and part of what I picked up on what Dr. Saunders said is the fact that it will review the prescriptions and the medicine that people are on and have been on for a long while, and maybe hasn't been reviewed enough. And if the evidence of this generates the fact that we do need regular reviews of medicines. We all know, I think, that there are bathroom cabinets stacked full of medicines that people don't take. They should be taking them, they don't take them for their various individual reasons. We all know that. And so I think any review and any instigation that will generate a review on people's medicines, I think has got to be welcomed. So I hope we learn a lot from this and go on, in fact, to ensure that GPs have a regular review of all medicines. Thank you.
Thank you for that. Jeanette, please.
Thank you, Chair. Gosh, this is a massive job, and I think it's going to continue to be a massive job, isn't it? I suppose I'm wondering who is going to be undertaking these assessments with people to ensure competence around their medication. I take 7 tablets a day. I've got it down to 7. And if I didn't have my own little box, I wouldn't be able to remember if I'd taken them, to be honest. And I'm only 72. I just dread to think about, you know, as I'm getting older. In my mum's latter years, she wouldn't have been able to cope without her Dosset box. And I just wonder who's going to be supervising this medication. I know that it doesn't suit everybody, but it suits a large number of people.
If I may, I think it's important that we are aware of the difference between a Dosset box, which is pre-populated and blister packed, and a sort of a morning, lunchtime, evening tub, you know, that lots of people use and that people find very, very useful. But a pre-populated Dosset box that's sent out in advance, that doesn't include changes that happened last week, doesn't include your acute course of steroids or your antibiotics, doesn't, you know, so it's I just wanted to stipulate that it is quite different, and obviously some people need support with their medicines, but a sort of a delivered pack isn't necessarily the answer for many people. However, for the people it is, that service should be available, and there are national online pharmacies that we can help people to use to have their medications delivered in a preset pack for the people in whom we've done a risk assessment and are happy it is the right thing. The other thing, I can't remember, somebody asked a moment ago about who's actually doing these reviews. So it should be a clinical pharmacist in most cases. So somebody who's really, really expert to do that review. And the review needs to also encompass the other needs of that individual, because these are 2,000 people about whom we have very little information. And if they've got this needs, they've probably got other needs. And so we want to actually, you know, properly assess them and take stock.
Thank you, Frankie. So does that mean that the clinical pharmacists are going to visit people at home?
If need be.
I think they'll need to.
I think it will depend, and as I say, and that's why it's that's in a way why the transition plan keeps changing, because we need to know the individual circumstances of every person, and in fact it may be that you really need a meeting with the carer as well as the individual, and that will vary.
Thank you.
Thank you. Alexandra, please.
Yes, I'm very mindful that the feedback captured by the current service provider demonstrated a high level of satisfaction with the current service, and it improved medication safety, enhanced independence and appreciation for the staff's caring and responsive approach. And I'm surprised that the service is being withdrawn, because I'm not absolutely clear who's going to provide that continuity. You've got the new neighbourhood models, but it's going to have to be somebody else. Can you clarify that the current service was undertaking the medication reviews and how they were qualified, because they're obviously doing that job very well. Will it actually add to the costs of the service generally if you're asking pharmacists to come out of their pharmacy to do reviews? Because I don't really think that pharmacies usually do that. But I'm sort of struggling to understand how the new system would be better, and the fact that it's different from other areas. Well, Norfolk has got an older age profile. It could well be that it's right for our area because it will extend to people perhaps in rural areas that would find difficult access. And also I'm a bit concerned that you said that people could be referred to an online provider for compliance aid. Well, lots of people may not have access to the internet. So help is out there, but it's matching people up with that, and they have that now. So have all these issues been looked at? Because sometimes it's actually better to keep what you've got that works, that people are happy with, rather than farm it out to different areas that may or not provide it.
There was a lot in that. The first point, talking about the medication reviews, so just to clarify, in the Norfolk Medicine Service, when a person is referred to it, they undertake a review and put it in the box and so forth. But the ongoing duty to perform structured medication reviews already sits with primary care, and that is, as Dr. Holliday said, that is business as usual. People should be getting structured medication reviews, and the way in which the primary care networks were set up and funded is that they tend to have a clinical pharmacist to undertake those structured medication reviews, but they don't always happen in the level of detail. And for these people, we know they've got additional needs, and so we want them to have an individual assessment, including a structured medication review, but a review of all of their needs and their eligibility for other support. So that's the sort of the first question, because I think a couple of your colleagues, it was almost as if people just started on medication and stay on it forever. Well, that's absolutely not the intention. And then in terms of, sorry, the second part you were talking about, the service so I think, I think the feedback from the provider of the service is that people who use it are very happy with it, which is great, and so we need to feed that into our future planning to make sure that people have as good a service or better. I'm struggling to remember the third thing you said.
Well, but is it actually clear who's going to be offering this, and if this service is withdrawn, that there will be an identified replacement for it?
Yeah. So that's why we need to do an individual assessment, because there are 2,000 people using this service. So those 2,000 people need to have an individual assessment to work out what they actually need, and it will vary. But bearing in mind we're in the process of really trying to empower our neighbourhood teams so that people have a local team that they can lean on whatever the need is. We'd much rather integrate services than have completely separate siloed services which are provided by somebody who knows nothing about what's available locally. So the intention is that we want to integrate it into their wider care so that the surgery knows exactly what's happening with that patient, and if the patient has social care needs, for example, that the social prescriber can pick up on them, and so on.
Thank you. Thank you. Does anybody else have a question? Lucy Shires, please.
I appreciate that you've sat here for quite a lot of today, and we have challenged you and you are sat alone, and that's not normally something that we would have, so apologies that you're taking fire for everything. I think hearing everybody in the room, we're concerned about patient safety. More so, it feels like that's a huge concern. A lot being unknown about these 2,000 people is generally concerning. My biggest fear from that is when they're reviewed that we'll realise there's a social care need, and that sits with this council's responsibility, and I don't know whether or not there's going to be immediate capacity to potentially support 2,000 people who've just had a newly realised social care need, if that is where we are. So we're going to need to do something as a committee to highlight this to our internal teams, Madam Chair, and I'm sorry to throw that at you. I think we don't have any data about how often the structured medication reviews are are happening. We don't have any data about whether or not our primary care networks are reaching an acceptable level of structured review for medication. So I think a recommendation I would like to make is that we receive some information back on that, and so that we can be aware. It can't just be this cohort of patients. We need to make sure that there isn't a wider systemic problem. So I think that would be helpful for us. My large concern is the move to digital, where we have highlighted that in a lot of our core 20 plus areas, there is a lot of digital inequity, and it's about digital literacy. So I don't know how this is going to help anybody that's receiving support for medication, who are then going to be pushed into potentially having to use a digital service to access any further information. So whilst I understand that there are plans, we don't know enough about the cohort to actually know how big this problem is and how much it's going to need additional support. So whilst I appreciate that you've got a huge problem to solve, I think that your timeline's too ambitious, considering that we don't understand the patient cohort. So my fear is we're going to run and do something, and I know nothing happens very quickly in local government or healthcare, and I understand that. My biggest concern is we're going to run and do something and we don't even understand the people it's going to affect yet. So I would be more supportive if it was delayed, I think, because we're going to affect a large group of people that we know nothing about, really.
Thank you. I mean, a delay isn't possible, is it, if Norfolk County Council are withdrawing funding? Are they withdrawing funding, or can they be appealed to?
I understand the council's decision was made some time ago. We were just informed that it had been made.
Thank you. Thanks very much.
I would add, though, that obviously we do have a responsibility for the safety of our patients. And so during the transition period, when we have an individual review with each patient, it is our duty to ensure they are supported. And if that means putting in interim measures, that is what we will have to do. And I think you said something along the lines of you didn't like the idea of being pushed to having to do something digital. Obviously, that is not our intention. I was just highlighting that is one option, that if people for whom a Docet box is the right thing, Docet boxes are available and we can actually have them sent directly to people's homes. So it was just to make sure that that's clear.
Madam Chair, then I'm going to assume that as the County Council has made the decision to withdraw a service, that we've done a full investigation as to who this is going to affect, so it shouldn't take too long for the committee to have sight of that, should it?
Thank you, yes. I've got Alexandra first and then Victoria. Is that okay? Thank you. If you could keep your comments brief, that would be great.
Thank you, Chair. My comment was, where in the County Council was this decision made? Because I don't remember it coming to full council. So I just wondered if a question could be asked about that and how this could be revisited. Thank you, Chair.
Thank you. Victoria, please.
Thank you, Chair. In addition to the detail on transition plans and the background to the decision being made, could we also have some assessment of the capacity in the community to actually pick up this work? Where are these community pharmacists going to, have they got the capacity to do this extra work? Have the neighbourhood teams? I mean, I'm just thinking about where I live, and I haven't seen an awful lot of neighbourhood teams or community or clinical pharmacists, and that's no disrespect to anybody, but there are areas of this patch that are deeply under-provided, and I wouldn't be comfortable with proceeding with this, even though it's already been decided, without more information that the people out there can actually help these very vulnerable patients. And so if that could be provided ASAP, that would be great. Thank you.
Thank you. Anybody else, please? No? Okay, I'm just going to summarise and then look at some proposals. So Lucy Galvin asked about satisfaction surveys, and people asked about the service stopping and looking at an impact assessment. Was it risk assessed? And she would like to see the risk assessment. Stuart Dark asked, when does the funding stop? Richard said he didn't know that the service had existed and felt that good GP services would negate the need for this. Victoria structured medication reviews and compliance. She was disappointed that no risk assessment had been done and wasn't comfortable with the plan. John Fisher welcomed this plan and he hoped it would lead to regular reviews. Jeanette said this was a massive job and who would do the assessments. Alexandra commented that the feedback gave high satisfaction excuse me, and was surprised at it being withdrawn. And were the current service providing annual reviews? She wondered how the new system would work and said that people may not have access to IT. Lucy Shires was concerned about patient safety. Not knowing much about the 2,000 people is a concern, and spoke about social care issues and a wider systemic problem, and was very concerned about a move to digital because of the inequity across the council. Alex wondered where in the county council the decision had been made because it didn't come to full council. And Victoria spoke of her anxieties of the capacity for the community to undertake this new work. Have I captured everybody and their concerns with this one? Okay, so I'm wondering a proposal, if we requested detailed information on the plan for the committee to be given to the plan, that's not the transition plans, but the approach to this. Would that be something that the committee would be happy with? And secondly, that we get information that we can communicate to residents about this and our residents about this. Would that go far enough, do you think? Okay, hang on a second. While I was writing my notes, Becky has other points.
Yep, so in addition to what the chair has raised there about the detailed information on this plan, further information has been requested on the assessment of capacity and including the appropriate documents to support that for the benefit of the committee. There's an additional request for data on the frequency of the medicine review schedules. There is a request for clarification of the decision-making process at Norfolk County Council to withdraw the funds for that service. And there is also a request for this committee to highlight to the appropriate committee at Norfolk County Council of this process and the discussion here today. So that's the four things that I've got written down from the floor, Chair.
Are the committee happy that we undertake these things? Can I have a seconder? Lucy Shires, can I have a show of hands, please? Thank you. Yes, that's okay. Thank you.
Chair, I'd like to register a vote against that.
You're voting against. Sorry, Deborah, I didn't see.
I think that this is a pragmatic approach. The service obviously is out of date and we ought to just deal with the consequences of the decision.
Okay. Thank you, Deborah. And Richard, you agree? So sorry, it wasn't a unanimous. Anybody else disagree? John Fisher, similar reasons? Thank you. Thank you. Okay. We still do it, don't we? Thanks, everybody, for that. We will now move on to the next part of the agenda, which is section 8. Frankie, I don't know if you want to stay or if you want to... You'll stay. Okay. The next thing that we're looking at is the appointment of a link member to Norfolk and Suffolk Foundation Trust. We have one role that needs filling. Can I just say this is a really, really, really important role to work with the Trust. I did that before I became the chair. I would really, really appreciate somebody with some enthusiasm, please, putting themselves forward, because this is so vital. Everybody's losing eye contact with me, apart from Lucy Shires. Could somebody please offer to do this? This is such important work, I think. Yes, Victoria, is that an offer or?
Yeah, I'd like to be involved.
You would?
Yeah.
Oh, thank you so much. One volunteer is worth anybody being press ganged. Do I have a seconder, please? Yes, Lucy Shires. Everybody is seconding. And a show of hands, please. Thank you so much. There are those of us that are very familiar with the Trust who would be more than willing to talk to you about it, although I'm sure you're fairly familiar with the Trust as well.
I've had a few skirmishes with them in the past, and I'll be happy to continue. Thank you.
Okay, thank you very much. Thanks, I so appreciate that. Okay, and was anybody else wanting to nominate themselves? Gosh, no. Pardon? It's too late, she's got the job. Okay, now we're going to look at the Forward Work programme. I'd like to invite Becky, the Democratic Support and Scrutiny Manager, to introduce the Forward Work programme report you have on your agenda. Before I look to cover the issue I raised under Chair's announcements at the beginning of the meeting. So over to you, Becky.
Thank you very much, Chair. So, so you've got the Forward Work programme, which brings together the items that the committee has agreed to as Appendix A. You'll see that there is a very healthy profile of reports coming through the committee all the way through to March 2027 and beyond. Obviously, today the committee has agreed further reports to consider and to add to that Forward Work programme. I'd say that we've got potentially 3 additional reports. Members, to be clear, are very welcome to propose changes to the Forward Work programme you have before you. And obviously, if you want to change the schedule to swap an item in favour of an additional item, that is for the committee to propose. Any member can propose a change to that schedule, and that needs to be agreed by the committee and will be reflected. Just to be clear about a new item that's on there for members' awareness, you will recall that information was previously circulated about the Wellness on Wheels bus, and then subsequent to that there was information provided in your last briefing note about the review of that and other outreach services. I've liaised with ICB colleagues, and the proposal is to bring early engagement to this committee at the March meeting to look at the strategic review of outreach services in the similar fashion to the item that you've just considered. So that is a pre-scrutiny type item for your consideration and agreement that obviously was not discussed at the last meeting. So just to specifically highlight that, but happy to take any questions. Thank you, Chair.
Thank you. Lucy Galvin, please.
Thank you. 2 questions. Thanks for the update on that. And thank you for the responses on the Wellness on Wheels bus from the ICB that was shared to us, I think, in a update. And then there were a few more questions on that, including questions around data for it, which I would like to ask formally that if it's coming as a pre-scrutiny item, which is good in March, as a strategic review of outreach services, that it does include that data that's been asked for about the actual usage of buses, etc. I welcome the fact that being widened out a bit further, but we need to be assured that we'll get the figures on that, so actual figures. It was a bit qualitative. And the second one is the contracts let by the ICB around the Vulnerable Adults and Walking Centre. I think you're going to talk a bit about that, Chair.
Yeah, if you could leave that for now, please.
Yeah, I'll come in after you've told us what you propose.
Yeah.
Thanks.
Yeah.
So yeah, just to directly respond to you, Councillor Gabbett, I'm very happy when liaising with the ICB to put that request for information in. Obviously, you know, I can't guarantee that that will be reflected, but I'll certainly put that in the scoping document for that report to make sure that request is there for the data that you previously submitted. So I will submit that again for you in respect of that item.
Okay, people, before I take any more questions, as I raised earlier, I have been made aware that the ICB's contract award decision for the Vulnerable Adult Service in Norwich is going to be, or already has been, called into the Secretary of State for Health and Social Care. I'm going to ask Becky if she can briefly explain the call-in process and the role HOSC has as part of that process.
Yeah, thank you, Chair. So, yeah, just before sort of getting into the detail and for the committee consider its approach, I thought it would be prudent to provide members with a reminder of what the call-in process is and how HOSC fits into that process. So, in January 2024, the Secretary of State for Health and Social Care has had the ability to call in any NHS reconfiguration at any stage. So it's the Secretary of State that calls in a decision. It used to be dependent on a referral from HOSC. Since that date, it is no longer dependent on a HOSC referral. So any person or organisation can submit a request for a call-in, and NHS commissioners have a duty to notify the Secretary of State of substantial service changes, which has been covered in previous discussions at committee. So the receipt of a call-in request by the Secretary of State doesn't begin any formal timescales. Under the new regime, the Secretary of State has complete discretion to decide whether or not to call a proposal in after reviewing the request, and there's no statutory deadline for the Secretary of State to consider the request itself. If the Secretary of State decides to call in a decision, the call-in process officially begins. Once a call-in begins, NHS organisations must provide all required evidence within 10 working days. The Secretary of State must then reach a final decision within 6 months of the call-in starting. So HOSC's role within that process, although the committee's referral power has gone, the HOSC scrutiny still matters as part of that process. When it's about reconfiguring services that have been notified to the Secretary of State, the ICBs have a duty to bring that to HOSC. And if a proposal is called in by the Secretary of State before the local committee has considered it, it is always good practice for HOSC to scrutinise it anyway. So it strengthens the transparency, ensures that that local perspective that this committee provides is available to be considered during the decision-making process of the Secretary of State. In addition, the Secretary of State is likely to take into account any subsequent HOSC findings submitted during the call-in period. So in summary, this committee and any other organisation or individual can request a call-in. It is for the Secretary of State to determine whether they accept it and will call in a decision. Where that is likely or where that is going to happen, the role of HOSC, it is good governance and good practice for this committee to have had oversight of the issue and that is specifically being called in. So it's not a requirement, but it is good practice in scrutiny guidance nationwide. Thank you, Chair.
Okay, thank you. So at this stage, I'm seeking confirmation that a call-in has been or is planned to be submitted. And if so, the specific content of the call-in. I'm also aware that the procurement process itself hasn't concluded. Given that it's good practice for local HOSCs to have scrutinised issues that have been called into the Secretary of State, and also noting that this issue has been raised regularly at this committee, I'd like to propose the following. Number one, that this committee requests to receive a report on the matters that have been raised through the call-in requests. And two, that the committee agrees to either the extension of the meeting on the 19th of March 2026 or the convening of an additional meeting subject to the availability of the appropriate information, whichever is the appropriate approach, to be agreed by myself as chair. Do members wish to comment on the proposals that I've made? And I'm also going to ask Healthwatch for a comment. And if you don't mind, I'm going to ask Healthwatch for a comment first, and then I will come back to members.
Thank you, Brenda. Excuse me. Healthwatch would actually welcome HOSC looking at this decision and talking about it, because we have spoken to various parties across Norfolk and Waveney in relation to the decision that's been made, and there are concerns, not in the way in which the procurement has been handled in any respect whatsoever, just there are concerns about the potential outcomes of the decision and the effect that that may have on patients and carers.
Thank you, Alex. Okay, colleagues, who else has? Lucy Galvin, then Jeanette, then Lucy Shires. Thank you.
Thank you for the update, and thank you, Alex, for welcoming this. As we all know, the Walk-in Centre and Vulnerable Adult Service and those other GP surgeries are lifelines for thousands of people who can't get a GP appointment, some of the most vulnerable in the community. And rightly, we've focused on it here because those services ease pressure on A&E and provide specialist support for people facing homelessness, addiction and other areas that we all want to get right and our priorities, and have been saved before thanks to overwhelming public support for them. So we do need full transparency from the ICB on why such a major change in provider is happening now. And I believe it's on the government website that the procurement's happened, so that's all quite in the public domain. I wanted to check, I wasn't quite clear, it's being called in and the Secretary of State, you're seeking clarity on where it is in the call-in process. So what will happen to services in the interim in this situation?
I've no idea, but I will find out.
Yeah, so I would like to support it coming to HOSC and to being kept abreast of what happens. I do feel we haven't really been kept abreast fully on this, so I'd like to really know what's happening, because it has gone from a provider that really saved the service and is a local company that is also a community interest company to potentially other providers that have got question marks. So I think we, as a committee, we really need to look at that. Thank you.
Thank you. Jeanette, please.
Thank you, Chair. Given that there are these concerns, and so that this committee can better understand how decisions are made within the ICB, and I'm talking about things like who makes, what is decided, who decides at what level, and relevant legislation that's looked at and considered. Could we have some kind of briefing paper from the ICB about the processes that they apply?
Okay, I think that's a separate issue, and I'll bring that one up and get the committee to vote on that one after we've dealt with this specific issue. Thanks, Jeanette. Yeah, Lucy Shires, please.
I don't quite know where to begin, if I'm honest. So I have a great deal of sympathy for Lucy, who has been challenging this process for what feels like an extremely long time. And as much as it says that a decision hasn't been made, the intention to make the decision is listed on the page advertised on the Gov website. So it's as near as there. And I think that was published the day before Christmas Eve, which is extraordinary when you think about the amount of people who won't be focused on it over Christmas. My huge concern is it's not only about the vulnerable people service, it's the walk-in centre and the health centre. All three were advertised at the same time. And when you look at who's intended to get the contract for the health centre and the walk-in centre, they were linked. They are part of a company that featured on Panorama for their questionable service to patients. So that will rock public confidence at using a service which has been dragged through the media, which is quite concerning. But when you look at who's going to get the contract for the vulnerable adult service, they've got a history of inadequate and requires improvement CQC ratings. And that in itself is a concern, because the cohort that that's intended to work with, we need to make sure that the care is there and solid. So the question has to be asked, who's making these decisions that will grossly affect public confidence and the confidence of service users? And at what point are we going to start looking at local healthcare professionals who are going to deliver services? One of these companies is from Yorkshire. I'm a northern lady. I've got nothing against northerners. You know, I've moved to Norfolk. But why are we looking elsewhere in the country to provide local healthcare? The system's messed up. We've got somebody that's going to make huge profits from this that isn't part of our community. So I don't understand how we've reached such a position that we're sitting here today and this just passively happens day in and day out. And I don't know how we solve it. And I apologise, Madam Chair, for throwing this all back at you to make sense of this disgraceful situation. But we have vulnerable people in Norwich and across the county who are going to be relying on service providers who don't have a fantastic history of taking care of people.
I have enormous sympathy, as you will know, for the points that you're making. I think one of my concerns is the limit as to what HOSC can do about this. We have to ensure that process is followed properly. I'm going to turn to Becky, who has extensive knowledge of everything, for her to clarify what the HOSC is able to do. Thank you.
Thank you, Chair. Obviously, you know, the role to scrutinise health providers is a big remit, and to be clear on what the committee can do, it's about scrutinising the provision of services or the decision-making processes to procure services, if there's seen to be any consideration where that's not being done for in the right way. So if policy or procedure hasn't been followed, or if outcomes are going to potentially have a detrimental impact on residents. The issues that Councillor Shires is raising about the outcome of a procurement process, unless it's within the call-in, which the call-in request, which has been mentioned but not cited, it would not necessarily be the role of this committee to start scrutinising the outcome of a procurement process if the procurement process has been followed, but the committee may wish to ask, in a similar vein that Councillor McMullen has raised, what is that process, so that the committee can scrutinise the process that is involved in the procurement and the commissioning of services that the ICB undertakes. So I'd say that the power of the committee isn't necessarily to call in or the outcome of a process if that process has been followed effectively, but the committee may want to look at the process itself as a scrutiny item. In relation to the call-in request, obviously, without details of what that is, it's difficult to define what would come to the committee. However, it would cover what would, if subject to the committee's approval, it would cover any areas that are raised within the call-in request, and then the wider issues and background that's led to the decision itself. So the request would be the timescales, the decision-making processes, and obviously anything that's within the call-in request that's submitted to the Secretary of State. So I'm afraid it's not a black and white answer, but I think there are definitely areas where this scrutiny committee cannot go, because obviously you're there to look at processes and outcomes. Yeah, I think that's all I would say on that, Chair. So some clarity, I hope, but obviously not necessarily the end of the discussion.
I mean, this is one of the reasons why I'm very keen that we have either an additional meeting or we swap things around and add this onto the meeting on the 19th of March. And I would really welcome the committee supporting that decision. It may well be that we could get an additional meeting as early as February, but I don't know at this stage until we have more information. Councillor Galvin.
Thank you. I'd certainly support an early meeting, but can we I've got a couple of questions really. I'm not clear from what you're saying, Becky, if we're going to see the call-in request or not, but I think we should seek to see it as a HOSC. We should seek to see the elements of it.
Yeah, if there is one, you can see it.
Yeah, well,
if we see it, you can see it.
So the point is the Secretary of State may have decided to call it in himself without a call-in request. Is that, so answer these in a minute, but presumably if he's calling it in, there is a request with a rationale on, or would he have just decided on his own without a request? So that's my first question. So the questions really around that the ICB could answer now usefully is how they'll guarantee continuity of care, as one provider did cover both services before. You'll recall they stepped in when the walk-in centre collapsed, when One Norwich collapsed due to financial mismanagement, they stepped in and took it over, and they're a community interest company, had done a very good job, and they did cover both services. So the question really that Lucy was asking as well is how will the profits stay in the local health economy, considering it was a local company? We're not against other companies coming in and providing things, but how do you make sure that the profits from that and the expertise and all of it stays within the local economy of Norfolk? And also how we guarantee social value in the awarding of contracts really through the ICB. You'll recall we did see the contract, and the last thing I wanted to say really was that thanks to Ed Garrett and the ICB for a swift response on questions that I submitted once we knew, but we didn't know as a HOSC. I don't think we were informed properly of the contract award, which again, I think is a shame actually, because we'd shown a lot of interest in it. We'd been prevented initially from looking at the contract and then told it was highly confidential, we couldn't share it with anyone, and then when it was let, we weren't told to who, and we found out via various other means. So I'd welcome a bit more close working with the ICB on this, because there's clearly issues that have been raised with me by multiple people. So thanks for your attention to this, Chair.
Thanks, Lucy.
So just to be clear, what the Chair has been made aware of and obviously discussed with myself is that a request to call in has been submitted. That is what we've been made aware of. We do not know the detail of that. We also, obviously, at this stage, don't know what the Secretary of State's view is on that. The Secretary of State may decide not to call in the decision. However, what the Chair has outlined is, members will recall this has been at this committee, there's been various information, and it seems prudent at this time, given that there is a request, to cover that and for this committee to take it forward. Obviously, if there was a call-in request, then has been alluded to that we're trying to find out more information about, any information like that would be pertinent to the report that you would receive and would be part of that report that you would receive to give you that context. So that's the information that you would get alongside any other information that it seems appropriate to scope out the item for your scrutiny and your consideration.
Thank you, Stuart. You have a question.
Yeah, Chair, it's just a comment. We've had a number of speakers speaking a couple of times on this, and I do appreciate that this is an emotive issue and an important issue. But going back to what your recommendation was, of that either we have a proper discussion on this with more information in front of us on the 19th of March and extend the meeting, or we have an additional meeting if more information comes in February. I think that would be the time that we actually raise a number of the points that are now beginning to come forward. So if you're looking for a seconder to what you're proposing, I'm more than happy to do so, but I think it might be about the time to take it to the vote and then actually have the discussion when we have that debate.
Thank you for that, Stuart. If I take that as a second, can we at this point then deal with this? Those in favour of the additional meeting or the extension of a meeting, please will you show? Raise hands. Oh yes, sorry, we're also requesting to receive a report on the matters that have been raised through the call-in requests as well. Okay, thank you. Thank you, so that's carried. Sorry, did Lucy, did you want to add to anything, or has your hand gone down now?
Sorry, I had one outstanding question, which could we find out what happens to the services in the interim? I think COS can urgently request clarification on that. And I'd like to know who told us about the call-in as well, because I suppose they can enlighten us a bit more.
Frankie, you wanted to?
Just to remind committee members that the procurement process is still live, in fact, and secondly to suggest the ICB is very, very happy and keen to work with you for this additional meeting for additional information.
Thank you. Thank you. Stuart?
Sorry, Chair, I was a bit premature. I've got a couple of issues around the forward work programme, but deal with it after we move on.
Okay. Leslie, did you have something to add to
Well,
this?
I just wanted to say that a community interest company is they're set up to benefit the community. It's in the title, so it's not always to make large amounts of money. But maybe if we do have that meeting, we could have a little breakdown of what that particular community interest company is seeking to do.
I mean, I'd be very keen for us to have as much information about as many points on this as we can have when we have the meeting. But I do think that an additional meeting is the time when we should be doing that. Does that satisfy everybody? Are you happy if we move on to the remainder of the forward work programme now? Okay. Yes, I'm going to go to Jeanette's point first. Becky, can you clarify whether or not this is a possibility to add to the forward work programme?
Anything is possible, Chair. You have to just agree it is a committee. But just to be, I mean, Councillor McMullen, you may want to just re-clarify this, but my understanding is that you were requesting a briefing paper on to outline the decision-making processes of the ICB, just for the committee to understand those processes.
Yes, please. What decisions are made at what level, who makes them, what legislation is followed, that kind of thing.
Put my microphone on. Can I have a show of hands, please, for that one? Agreement on that one? Yeah, well, we're happy to add that to the list. Anybody? Stuart, you have some things you wanted to add.
Yeah, thank you, Chair. One little one and one bigger one, and it might not be that something that councillors all need to vote on. It might be something that Frankie says that they're willing to do. In July, we've got a report coming forward from the Norfolk and Waveney Hospitals Group in relation to an update of how things are going. I think given the paper headlines around the surge in demand that's placed on the hospitals and has been placed on the staff, and they've been working flat out over the winter, it would be useful if we could have some figures in that of actually how have we coped with the demand this year? Has it been any different to last year, and what lessons are learnt for what we're likely to have again next year? Because July would probably be about the right time for that, for any lessons. But I'm quite happy for answer whether that could be included or whether we might need to vote on it.
Would you be looking just for the information around winter as a reflection of what that's looked like compared to previous years?
And I'm hoping not to make it overly complicated, because we have actually got a paper coming forward, so it's just asking whether we can have a section in that kind of details the, you know, whether there was an increased demand, which it seems likely, and how everyone coped with it. Probably put the staff in a very good light as well, considering how hard they're working.
I would. My suggestion to the committees is that would probably be a briefing paper that we can get to you rather than a scrutiny report, which means that that could be given out to the committee prior to that July meeting, and then July can focus on the overall hospital group. So that would be my suggestion, Chair.
Are you happy with that, Councillor Dark?
Yeah, thank you. And then moving on from that, the one that is probably a major one that I'd probably like more than a briefing paper, that it should actually be formal. Looking at the formal reporting of this, and I apologise if it's something that other councillors have seen more recently. We've had themes in the meeting today around dignity and around also talking about buses and getting people to hospital. In our forward work programme as HOS, we haven't got coverage around, at the moment that I can see, around the East of England Ambulance Service and their response times. I'm aware in my division recently of 2 cases where people were left, frail people, elderly people, with quite lengthy waits on the pavement because an ambulance couldn't arrive. Now, I'm speaking with other councillors, I'm aware that others have similar ones like that. Given that that's probably going to be interesting for the public around actually how are we responding to that, it would be really useful, I think, at some point in the forward work programme that we've got listed, to have an update from the East of England Ambulance Service around what their actual response times are, what their capabilities are, and if there are any deficiencies, what their action plan is to actually deal with those, because I think that's an important role of us, because it's an integral part of the care system. Thank you.
Becky's suggesting that we start off by asking for a report, and then depending on what the report says. Sorry, a briefing, not a report, a briefing. And then when we've seen the briefing, we can then see, because we have such a huge list of things on the work programme. Would that satisfy you, or would you like it to be added? Becky can, she knows the rules. So.
They're not rules. All I was going to suggest, Councillor Dark, was obviously we would need to change something to bring that sooner, so the committee can determine if they want to do that. But equally, some initial information on the East of England Ambulance Service to members might be useful as background context on performance, and it may be that as a committee you actually wish to look at specific areas of their service rather than an overview report coming to the committee. On receipt of that information in a briefing, you may have specific concerns or areas that you want to look at in a deep dive within a scrutiny session, and then a report could then be brought together focusing on those specific items. It's obviously a large service, so you might want to take that approach just to try and hone in on, as a committee, where you want to focus on particular elements of their service, or you may not, but that's a suggestion that might help you to have an effective scrutiny item in the future.
Yeah, I can see the logic in that. My one concern around it is if we ask for a briefing note, is actually making the timescale that actually it comes forward promptly and in the areas which we want, which is, or which I'd like, which would be in terms of that they have commitment to response times. How are they achieving them? How consistently in terms of them, and also geographically, how have we got different geographical coverage across the county? But I'd like to have that briefing note fairly quickly, because I think it's certainly for me an area that I've got a blind spot on at the moment that I know is important.
How quickly can we ask for a briefing note?
Today, I can ask today.
Okay.
Yeah,
Yeah.
I can do my utmost, and then we can make sure either reports back.
Okay.
Or I update the committee at the next meeting.
Okay.
You'll need to take votes on that.
Yeah, so can I take a vote on that, please? Are people happy that we ask for a briefing note? Yeah? With a view to a report, yes. Okay, thank you very much. And if Becky is on the case, it will be done. Thank you. The next person is Jeanette, not MacDonald, McMullen.
Thank you, and I'm not sure if this is possible. We have raised it before, or I've raised it before, but I would like to have a more in-depth look at the over 40s health check. I know that Becky sent out an overview just before Christmas, but I'm aware that these health checks are still going on. And again, we have a private company, I think, making a lot of money out of this. I can't see any evidence of effectiveness, and I just wondered if we could get this on the agenda. I know that the service isn't commissioned by the ICB. I think it's another group, isn't it?
Becky has a response for you.
Yeah, apologies to the committee members. I'm still in the process of getting information around those checks. I believe they sit with our public health team at Norfolk County Council. So it's in my in progress box, and I have got that on my work programme, but unfortunately, I apologise, I haven't reflected that as in progress in the forward work plan, but I have still got that as something to bring back to the committee when I've got relevant information, Councillor McMullen.
No problem, thank you.
Do I have anything else? I have Leslie Bembridge, please. I'm really sorry, Leslie, I'm just going to ask you to postpone and let Victoria go first, because I know she has to leave. So if you don't mind, thank you.
Oh, that's really kind, thank you. I'd like to look at out of hours and 111, actually, and that would be really interesting in the context of acute pressure, and also in terms of ambulance response times, because they're all tied together. But there's a lot of, I mean, it's the majority of the week actually is out of hours rather than in hours, and it's incredibly difficult to get out of hours care in my patch in North Norfolk. And they do a brilliant job, and I'd like to have more information on that, please. I don't mind if it's a briefing or a discussion, thank you.
If it's okay with you, we'll start with a briefing note and then take it from there.
And could I just add also that could we expand the autism section onto neurodiversity more broadly?
Yes.
That would be brilliant. Thank you very much.
Can I just need a show of hands for the briefing note. Yeah. Yeah. Good. Okay, thank you. Okay, now you, Leslie, thanks for giving way.
Well, it was just talking about the ambulance service. I mean, a little bit more detail could be useful. For instance, when we did one of our, I did a quality review at the A&E at the Queen Elizabeth Hospital, and there were 3 ambulance crews there. So presumably they have to stay with the patient unless the patient is admitted. So that is obviously where there might be a delay. I mean, it was Saturday morning at 10 o'clock, and it was very, very efficient there at A&E. So people were being moved on, but perhaps that could be included in the report we get. How long do they have to wait sometimes? Because we know that, you know, if they can't get into A&E, they have to wait out in the ambulances for some time. But it would be good to know whether they can go off and do another job and then another ambulance is called to take the patient home. Thank you.
Smashing, I don't think there's a problem with that. I don't think we need to vote on that either. Anything else? Oh, sorry, Becky has.
Yeah, so obviously, like I did allude to earlier, the committee has proposed 3 additional reports, which the options are, if members are keen to see those reports that have been proposed, if they have a view to them coming to the future meetings, members would have to propose to the committee something that's going to change so that that programme can be reviewed. So I just wanted to make sure that members had that opportunity to do that in the current item. Otherwise, I'll work to see where we can fit that information in, and members will obviously respect the fact that it is a full, healthy programme of activity. But I just wanted to flag that that opportunity is there if members want to suggest any swaps on that proposal before you agree the appendix. Thank you, Chair.
Thank you, everybody. Thank you for being here, and thank you for being what I consider to be probably the best committee that happens in this room.
Can you agree the forward work programme?
Oh, sorry, I haven't agreed the forward work programme. Can I agree the forward work programme? Subject to the amendments, yes. Yeah, people are happy with that. So just to go back to say thank you so much. Thank you, Frankie, for sitting in the hot seat today. And thank you, Alex, for being here. But really, as a committee, you put thought and effort into this and really do raise concerns on behalf of the people of Norfolk. So I cannot thank you enough. And I do appreciate every one of you. Thank you. See you soon. Bye.